Welcome, my dear friends, to today's session, which is revision for your ophthalmology for the upcoming exam. I'm Dr. Anuradha Dhawan, your ophthalmology faculty, and I welcome you to today's session. The purpose of this session is, dear friends, to revise the ophthalmology in a productive manner to cover all the high yield topics so that you have a comprehensive revision, but comprehensive yet targeted so that it's productive for our upcoming exam. So I'm sure this session will be quite useful for you to revise what we did in our online classes. That will boost your own revision and that will help you feel confident about the upcoming exams. So let me welcome you once again to revision of ophthalmology session. Welcome, my dear friends, and let's gear up to start our session today. My mail and the Telegram channel link is there. If you have any doubts or anything would you like to share with me or discuss with me, you are most welcome to do that. And let's go ahead with revision of ophthalmology. So we'll be doing it topic wise. So I have divided it into all the different topics which we did in the online classes, and we'll be going through the important points of all those topics. So let me begin with the optics and refractive errors part. And in the optics and refractive errors part, the things which we must remember, which we should not skip. So let's start with that. So, dear friends, as you know, the eye is a refractive structure. Okay, we have learned that the purpose of the eye is to refract the light which it receives so that an image is formed at the retina. An image is formed at the retina. So, the total refractive power of the eye is taken as plus 60 diopters. Plus 60 diopters. So, plus 60 is a kind of a round figure, as you can see. Plus 58 to 60 diopter is the taken as the proper value. So for sake of remembering it, take it as plus 60 diopter, out of which majority is contributed by cornea. So cornea is your main refractive surface. Okay, cornea is the main refractive surface of the eye. The major contribution to the refractive power of the eye is by cornea, which is around plus 45 diopter. The second important refractive structure in the eye is your lens, is the lens of the eye, which contributes approximately plus 15 diopter. Okay, so these figures are for you to remember it easily. Okay, it's plus 60 total, plus 60 total, plus 45 by cornea and plus 15 by the lens. Okay. Now, have a look at this figure, beta. Have a look at this figure, because this figure will help you in remembering that how the refraction is occurring, So, as you notice over here, friends, the light rays are coming. So, when they are coming, they will be striking at cornea. So, they will be striking at cornea, and this is the interface. Air corneal interface, we call it as air corneal interface, where maximum refraction is occurring. So air corneal interface where maximum refraction is occurring. After that, the rays, they will pass through the lens. As you notice here, the rays are passing through the lens, and once they pass through the lens, they converge at a single point at the retina, what is known as fovea. Okay, so here you are noticing that. Okay, so here you are noticing that they have to converge at single point on the retina where a clear image will be formed. Okay, so this concept I will be just explaining once more in a line, because that will help you understand what the refractive errors are. The rays of the light, they are refracted by cornea. The maximum refraction occurs at air corneal interface. Then they are further refracted by the lens, and then they converge at a single point at the retina If they converge at a single point at the retina, then a clear image is formed. It means it is a normal refraction. There is no refractive error there. Fine. Now, if this does not happen, that leads to an eye having refractive error. So, if this does not happen, it means there is a refractive error. And what can be that refractive error, friends? Have a look here. Now, you saw the previous diagram and now look at this diagram. So, what is happening here, my dear friends? The rays of the light are coming, okay, they are passing through the cornea, they are passing through the lens, but they are converging at a point in front of the retina. Retina is here, this is retina, but they are converging at a point in front of retina. Now, when this is happening, we call this refractive error as myopia. So, this is what happens in myopia. Okay. Now, this can be asked as an image question also. So, please keep keep noting it down. What can be asked as an image question? I'll be pointing it out throughout. What can be asked as an image question? What can be asked as a one-liner? What can be asked as a clinical case scenario? So, please keep in mind that thing, beta. So, they can show you this image and they can ask you what is the diagnosis from this diagram. So, what do you see here in this diagram? That the rays of the light, they are converging not on the retina, they are converging in front of retina. So, that is the diagnosis of myopia. Okay. So, myopia is also known as nearsightedness. In myopia, the patient is able to see near clearly but has difficulty in seeing distant object. Okay. Now, there have been questions in the past as a clinical case questions also, beta. The clinical case question, how the clinical case question will come? Please listen here. A child, something like an 8-year-old child or a 7-year-old child is brought by the mother with complaint of difficulty in seeing blackboard in the class. Okay. So, blackboard in the class. So, you can write it down here. A clinical case scenario, difficulty in seeing blackboard. So, this typical complaint is suggestive of that this child is having a refractive error, most likely myopia. Okay. So, clinical, there can be two questions here, one based upon your diagram, one based upon the clinical case scenario. So, a child having difficulty in seeing blackboard, or a child who squeezes the eyes to clear up the vision. So, these will be the complaints in these cases. So, if there is something like that in the clinical case statement, so high chances that this is the case of myopia. Okay. So, this is about your first refractive error, that is myopia. Now, coming to the second one. Now, have a look here, beta. Now, have a look here at this diagram. Now, what is happening here? The reverse of the first one. Is happening here. The light rays are coming. They are passing through cornea. They are passing through lens, but they are not converging on retina. They are converging at a point behind the retina. Okay. It's clear from the diagram. They are converging, the light rays are focusing or converging at a point behind retina. Now, this is what happens in the hypermetropic refractive error. This is what happens in hypermetropia. So, this is your second type of refractive error, which is known as hypermetropia, where the light rays are focusing behind the retina. Right. So, in these kind of patients, mostly the patient, they present with eye fatigue, asthenopic features. The patients they present with, in the clinical case scenario, it can be that there is eye fatigue, There is asthenopia. Asthenopia means eye fatigue only. These patients, they tend to rub their eyes to clear their vision, so they have risk of developing stye. So again, it can come as a image based question, it can come as a clinical case scenario. So if this image is there, you can identify this is the image, the refractive diagram depicting hypermetropia. If there is a clinical case scenario, patient is having eye fatigue, asthenopia, recurrent episodes of stye, then again the chances are that the patient is having refractive error of hypermetropia. Okay? So I hope we are clear about what is happening in myopia, what is happening in hypermetropia. Now, we have to correct this. If the patient is having refractive error, the patient is not seeing clearly, we have to correct this refractive error. So for correcting the refractive error, we will be giving the appropriate glasses to the patient. Okay, and in the glasses we will be giving the appropriate lenses to the patient. So what is the correction of myopia? What is the correction of hypermetropia? Let's see now. Okay. So what is the correction of myopia? So for correction of myopia, beta, the most easy thing to remember is, I always tell this, so please try to understand it like, myopia means more convergence. Myopia means, remember it as simple, easy to remember, myopia means more convergence. M for myopia, M for more convergence. So since the eye is converging more, that is why the rays are focusing in front of the retina. So if it is converging more, the correction will be, you will be giving a lens which will reduce the convergence. So you want to decrease the convergence by giving a minus lens. So you give a minus lens. Okay. So correction of myopia, very easy to remember, M, M, M. M for myopia, the eye is having more convergence, I give minus lens. And which lenses are the minus lenses? Concave lenses. The concave lenses are the one which are your minus lenses. They are also called as divergent lenses or diverging lenses. Okay, so they are also called as diverging lenses. So see here a concave lens. So if you place a concave lens, that reduces the convergence. So the rays of the light which were focusing in front of the retina, now they are focusing absolutely on the retina, thus helping in forming a clear vision, thus helping in making the patient see clearly. Okay, so this is the thing. So please remember, correction of myopia is done by concave lenses. The word biconcave is also used, beta. Biconcave. Biconcave because both the surfaces, you see here, this part is also concave, this part is also concave. So this type of the lens is known as biconcave. So this question has been asked in your exams also. So biconcave lenses are used for the correction of myopia. Okay, right? Now, moving further, how would you correct hypermetropia? How would you correct hypermetropia? Now, in hypermetropia, as I told you, the things are kind of reverse of myopia. So, if there was more convergence in myopia, so here the eye is having less convergence actually. Okay, so that is why the rays are focusing behind the retina. So, if here I have to increase the convergence. Here I have to increase the convergence. So for that I need to give converging lens. I need to give converging lens, and which is the converging lens? The convex lenses. So here I have to increase the convergence. So I give converging lens, which are your convex lenses. So convex lenses, as you see here, the convex lenses are also called biconvex lenses. They are helping in focusing the rays of the light on the retina. So which were behind the retina, now it is being focused on the retina. Okay. So the correction of the hypermetropia is by biconvex lens. So this again has been questioned, beta. This again has been often asked question. The correction of the hypermetropia is done by biconvex lens, or the biconvex lens is used in correction of which refractive error? Hypermetropia. Okay, so is it clear now? Now there are some more uses of the biconvex lens also. So biconvex lens, where the biconvex lens is used, so it is used in number one, as I also just now told you, in correction of hypermetropia, in correction of hypermetropia. Besides this, it is also used for correction of presbyopia. Presbyopia. So remember, presbyopia is difficulty in near vision with age. Difficulty in near vision with age. So there also we need to give biconvex lens, or also called as plus lenses. The biconvex lenses are plus lenses for the correction of presbyopia. And the third use of the biconvex lens is in the cases of aphakia. Aphakia. Okay. So what is aphakia? When after cataract surgery, you have not put the intraocular lens in the eye, we call it as aphakia. We'll be discussing it a bit more also. So there also we are using plus lens or the biconvex lens for the correction. So this also has been your question, beta. So all the points which I am telling you have been your questions, are the high yield points. So please concentrate, stay there. Biconvex lenses or plus lenses are used in three conditions: correction of hypermetropia, correction of presbyopia, and correction of aphakia. Okay, and remember what we learned just now, concave, biconcave or minus lens is used for correction of myopia. So it is simple to remember. Okay, right? Okay, so now let's go further, and in the refractive error for myopia, we need to remember few more important points and a condition what is known as pathological myopia, friends. Pathological myopia. Now what is pathological myopia? So pathological myopia is high myopia with degenerative changes in chorioretina, that is in the retina and choroid, as a result of myopia. Okay, so pathological myopia is defined as, you can say, high myopia plus chorioretinal degeneration. Okay, degenerative changes which occur in the retinal tissue and in the choroidal tissue, that is what is seen in pathological myopia. So high myopia usually more than -6 diopter, more than -6 diopter. And what are the changes which we see? Because these changes are again important to remember. What all changes you can see in a case of pathological myopia. So let's read them, and I will show you also the figures so that you remember them. Okay. So first of all is your temporal crescent. Temporal crescent. Temporal crescent means a crescent kind of marking, you can say, around the optic disc. So I will just show you. That is known as temporal crescent. It's a crescentic atrophy around the optic nerve. We call it as temporal crescent. Then there is what is known as posterior staphyloma. Posterior staphyloma. Friends, wherever there is a word called staphyloma, so staphyloma means bulging. Okay, staphyloma means bulging. So when the eyeball is bulging or it is ectatic, then it is called staphyloma. So when it is bulging posteriorly, that is towards the back part of the eye, that will be posterior staphyloma. So posterior staphyloma is, you can see, the bulging at the posterior pole of the eye. Bulging at posterior pole of eyeball. Okay. So this is again seen in the cases of pathological myopia. Then the third thing which can be seen is what is known as Foster-Fuchs spot. Foster-Fuchs spot is a hemorrhage seen at macula or fovea. Hemorrhage seen at macula or fovea in a case of pathological myopia is called Foster-Fuchs spot. Okay. Then we see what is known as lacquer cracks. So lacquer cracks are a kind of breaks in the choroidal tissue. So typically there is a structure called Bruch's membrane, which is a part of choroid. So there you see these lacquer cracks. So just remember the word lacquer cracks. So they are also seen in pathological myopia. Then there can be formation of CNVM. What the CNVM stands for, friends, is choroidal neovascular membrane. Choroidal neovascular membrane. Okay, so there is a new vessel membrane formation in the choroid, again in the cases of pathological myopia. Okay, then the peripheral retina can show degeneration, most commonly what is known as lattice degeneration. In the lattice degeneration, there is thinning of the retinal tissue, due to which there can be formation of retinal holes. And whenever there is a retinal hole, there is always a risk of retinal detachment. And this type of the detachment, friends, is known as rhegmatogenous retinal detachment. So that can also be present in a case of, or it can occur in a case of pathological myopia. Okay, so all these can be, friends, your one-liner questions. They can be your one-liner questions. These are the findings in pathological myopia which are seen in the choroid and the retinal tissue because of the degenerative changes. So I'm enumerating once again what all you can see. You see temporal crescent, you see posterior staphyloma, you see Foster-Fuchs spot, you see lacquer cracks. There can be formation of choroidal neovascular membrane. In the peripheral part of the retina, there can be degenerative changes called as lattice degeneration. In the degenerative areas, there can be formation of the retinal holes or tears, which can lead to rhegmatogenous retinal detachment. Okay, so please remember these changes. I'm going to show you some figures to make to remember these changes easily. Okay, now these are unlikely to come as an image, but just to make you understand so that you don't forget that what I just spoke to you about. So if you see here, beta, this is the temporal crescent. This is your optic disc. So if it is only on the temporal side, it is called temporal crescent. If it is involving all around the optic disc, then there is another name given to it, which is called as peripapillary atrophy. So basically temporal crescent and peripapillary atrophy are the atrophic changes only. If it is only on the temporal side of the optic disc, you call it as temporal crescent. If it is all around the optic nerve, it is called peripapillary atrophy. Okay, then you see these atrophic changes in the macular area. If you notice carefully, this part is actually bulged. It is difficult to see on the figure, but this is how it will look in posterior staphyloma. So this is actually showing you posterior staphyloma. Okay, so again a feature of pathological myopia, your one-liner question. Then if you notice here clearly, beta, in this figure, you see these lines, okay, these are your lacquer cracks. Okay, so these are not going to come as an image. It is very unlikely. This is for your understanding. Friends. Okay, and how the lattice degeneration and the holes they look like. So this is lattice, means something like a net. So you see here, this is the lattice degeneration, a net like degeneration in the peripheral part of the retina. And when the tissue becomes very, very thin, it can lead to the formation of a retinal hole. So what you are seeing here is a retinal hole. Fine. So these are the changes in the retina or in the fundus in a case of pathological myopia. Okay, friends. So we know what is there in myopia, we know what is there in hypermetropia, we know how we are correcting this. Now coming to the third type of the refractive error, what is known as astigmatism beta. Astigmatism. Okay. What is astigmatism? So astigmatism is different from what we just discussed. In astigmatism, the light rays, they do not focus on a single point. Okay, so if we take cornea, okay, that cornea is a kind of 360-degree structure. If the refractive power of the cornea is same 360-degree, then the rays of the light, they will focus at a single point. But when the power of the cornea is different at different axes, or what we call as meridia, then it leads to astigmatism, because in some meridia the light rays focuses at one point, and in some meridia the light rays, they focus at a different point. So that is known as astigmatism. Okay, so that type of the refractive error, my friends, is known as astigmatism. When the light rays do not focus, light rays do not focus at one point, one single point. Okay. Now astigmatism is of different types depending upon how the different meridian they are behaving. Okay. So for astigmatism we take two meridia. Okay, so to describe astigmatism we take two meridia, one vertical meridian and one horizontal meridian. They are known as principal meridian beta. Okay. So in these principal meridian we see that what is happening at vertical meridian, what is happening at horizontal meridian. Depending upon that, astigmatism can be of 5 types. Simple myopic astigmatism, simple hypermetropic astigmatism, compound myopic astigmatism, compound hypermetropic astigmatism, and mixed astigmatism. Okay, so let me explain to you with the help of this diagram. So you just need to look at this diagram, and that will make you understand what I am talking about. So look here beta, look at the picture A. So what you are seeing in this figure A, you are seeing that at one meridian the light ray is focusing on retina. Agree? Okay, and in the other meridian it is focusing in front. So whenever it is in front, please remember it is myopia. Okay, so here one meridian it is on the retina, it means in that meridian there is no refractive error, but in the other meridian it is in front, it means there is myopic refractive error. So when there is this refractive error only in one meridian, and that is myopic, we call this type of astigmatism as simple myopic astigmatism. Okay, so at one no refractive error, at other myopic refractive error, so that will be, friends, simple myopic astigmatism. Okay, is that clear? Now coming to the second situation, again have a look here. See, this is on retina, this is on retina, and this is behind retina. The second meridian behind retina. So behind retina means hypermetropic. So if one meridian is on retina, it means there is no refractive error on that meridian, but at the second meridian it is behind the retina, it means it is hypermetropic. So this kind of the astigmatism, friends, is called as simple hypermetropic astigmatism. Is that all right? Okay. Now coming to the third kind of situation. So in this you see one meridian is in front. Okay, so this is in front. The second meridian is also in front, but they are not at the same place. So it means the power is different. They are not at the same place. So one is in front, the second is also in front, but they are not at the same plane or at the same place. So both the meridian are myopic, but not equally. Okay, so we can understand it that both the meridian are myopic, but they are not equally myopic. So such kind of astigmatism will be, because both meridians are myopic, it will become compound myopic astigmatism. Compound myopic astigmatism. Okay, right? Then coming to the fourth kind of the scenario, coming to the figure D beta. Again have a look here. So this is behind the retina. This is behind the retina. So both meridian behind the retina. So both are hypermetropic but not equal. Not equal. So both meridian hypermetropic but not equal. So it becomes compound hypermetropic. It becomes compound hypermetropic type of astigmatism. Okay, right? Then the fifth scenario is, or the fifth situation is, one meridian is in front, this meridian is in front, this meridian is behind the retina. Okay, so one meridian is myopic, one meridian is hypermetropic. So this type of the astigmatism is known as mixed astigmatism. This type of the astigmatism is known as mixed astigmatism. Okay, so these are the 5 types of your astigmatism. These 5 types are known, they are like, this kind of is a part of regular astigmatism. Regular means that there are 2 defined meridian, as I told you, one vertical, one horizontal. One vertical, one horizontal. So in this 5 types are there: simple myopic, simple hypermetropic, compound myopic, compound hypermetropic, and mixed type. Okay, so if any questions come on this, we now understand what is this astigmatism and what are the types of astigmatism. Okay, now how the correction of the astigmatism is done, beta? The correction of the astigmatism is done with what is known as toric or cylindrical lenses. Okay, so please remember, this can be your one-liner question. The correction of the astigmatism is done with toric or cylindrical lenses. Fine, right. Now going ahead, another thing which we should know is, what is pinhole? What is a pinhole? Again, important topic, the questions they have been coming here. So let me show you the figure here so that you understand it better. So do you see this image here? This is showing you what is pinhole. So in pinhole, there is this black disc in the center. So it is occluding everything except that there is a small hole in the center, a small hole or opening. This is a small hole or opening here in the center of this black disc. So when you place it in front of your eye, when you see through this small hole, so only the light will pass through that central area. Only the light will pass through that central area. Okay, so what is the use of this pinhole? This pinhole, when we test the vision of a patient, okay, so when a patient comes to you with a complaint that I am having problem in my vision, I am not able to see clearly. So one main thing you want to know whether the problem of the patient is due to a refractive error, which we just discussed, that patient is myopic or hypermetropic, because then you can correct it by giving the correction, by giving glasses or something else like lens, contact lenses, or you want to know that whether there is some other problem in the eye. So the pinhole will tell you that. Okay. So I told you there is a central opening here. the diameter of this central opening is just 1 millimeter, a very, very small opening, and it allows only central rays to pass through this. Now, when the patient looks through the pinhole and there is an improvement in the visual acuity, very important, listen here beta, when the patient looks through the pinhole and there is an improvement in the visual acuity, it means the cause of the vision problem was refractive error. The cause of the vision problem was refractive error. Okay. But if when the patient looks through the pinhole and there is worsening of the visual acuity, that he was seeing better earlier, but looking through the pinhole he is not able to read as good on the chart, it means there is some central pathology. Central pathology means there is some problem in the central part of the eye. So what can be, like if there is, any disease of the macula, the central part of the retina. So if there is any disease of the macula, macular diseases, or there is central corneal opacity. If the cornea becomes opaque, the vision will not be clear. Or there is central cataract, that if the lens in the center is opaque, so that will also block the vision. So the worsening of the visual acuity indicates that there is some central pathology in the eye in the form of either some disease of the macula or some central corneal opacity or central cataract. Okay, so this again beta very important. The question has been coming about what happens when the patient sees through the pinhole. So again I am telling you, even they can show you the image of the pinhole also. So how will you identify? A small opening in the center will help you understand that this is a pinhole. And if they say the vision improves after looking through the pinhole, it means it is a refractive error. If they say the vision gets worsened after looking through the pinhole, it means either it is a disease of macula or central cornea or there is some central cataract. Okay, so you won't forget that, right? Okay, now going ahead, and something about aphakia. So I touched upon the aphakia earlier also. So aphakia means aphakia, phakic or means lens. Okay, the phakic term is used for lens. So aphakia means absence of lens. Aphakia means, friends, absence of lens. So when a patient will be aphakic, aphakia means absence of lens. So absence of lens, when can this happen? So mostly it happens, friends, when we do a type of cataract surgery, what is known as intracapsular cataract extraction. Okay. So when we do intracapsular cataract extraction, we cannot put the lens in the eye at the same sitting of the surgery. So patient has no lens in the eye. Okay. Very rarely it can happen after trauma also, like the lens just falls behind in the vitreous cavity. So when there is no lens inside the eye, either natural or implant, that condition is known as aphakia. So once the patient is aphakic, the lens is having approximately plus 15 diopter of the power I told you in the beginning. So when there is no lens, the eye becomes highly hypermetropic. So this is a stage in which the eye becomes high hypermetropic. Okay, because there is absence of the lens. So to correction of the aphakia, the glasses which are given, they are high plus glasses. They are high plus glasses. Okay, high plus glasses they are given. Now what happens with these high plus glasses? These high plus glasses are known as aphakic glasses, right? So you get me there, beta? What is aphakia? The absence of the lens in the eye is called aphakia, which usually occurs when there is, a cataract surgery is done in the form of intracapsular cataract extraction and no lens implant is put in the eye. So when there is no lens in the eye becomes highly hypermetropic and the vision will be blurred. So you give a correction. This correction is usually in the form of high plus glasses. These high plus glasses are known as aphakic glasses. Aphakic glasses. Okay, so this is what this patient is wearing. If you see, the glasses which this patient is wearing are high plus glasses, right? Now these high plus glasses or aphakic glasses have many disadvantages. They have many disadvantages, and what are these? So this is what is written here. These glasses they call high image magnification. So you must have seen through a plus glass. If you see through a plus glass, everything appears magnified. Through a convex glass, everything appears magnified. So the images they become highly magnified. When the images they become highly magnified, the field of the vision becomes narrow. The range of the field of the vision becomes narrow. Okay, right? And if there is aphakia in one eye, okay, so one eye is seeing normal image, the other eye is seeing magnified image. So there is difference in the size of the images seen by the two eyes. This is what is known as anisokenia. So this is what is known as anisokenia. So this again can be a one-liner question. What is anisokenia? Anisokenia, friends, is different size of the image. Different size of images seen by two eyes. If one eye is seeing a normal size image, the other eye which is looking through the aphakic glass will see a magnified image. So there will be imbalance. So this is known as anisokenia. Obviously the patient will not be happy. Okay. Then these glasses they have various spherical aberrations, again due to which the image distortion is there. So one type of the distortion is known as pin cushion effect. They also cause scotomas which are known as, one scotoma is known as jack in the box scotoma, jack in the box scotoma, or this is also called roving ring scotoma, roving ring scotoma, and the second type is the ring scotoma. So these two are different, friends. So sometimes there is a confusion. Ring scotoma means because, like, in the center of the glass, the patient is able to see clearly. But at the periphery of the glass, due to the aberrations, the vision is not clear. So that leads to ring scotoma. Then roving ring scotoma is also called jack in the box scotoma. That is something different. In that, what happens, see, if the patient is moving the head, then image seen is different. But if he moves only the eye, then the image seen is different. So what happens, he feels that the objects are coming and going in the field of the vision, though they are always there. But he is not able to see because the field of the vision is changing. So that is roving. Roving means moving. So that is roving ring scotoma. Okay, so this is for your understanding, but please remember for your exam because they can be asked as one-liner questions. So these are the disadvantages or the changes which are seen if a patient wears aphakic glasses. There will be image magnification, narrow field of vision, anisokenia, pin cushion effect, and two type of the scotomas seen. One is your ring scotoma. The second is roving ring scotoma, which is also called jack in the box scotoma. Okay, so if aphakic glasses are not good, then what you should do? So then what you should do? Then what we should do is, so in a patient of aphakia, the better correction is done. The best correction of aphakia is in the form of intraocular lens. Okay, so best is you put the lens inside the eye. This is called secondary intraocular lens because you did not do it at the primary surgery. So best is you do intraocular lens implantation as a secondary surgery. And the second best is contact lenses. So rather than the glasses, you give contact lenses, beta. The second best is contact lens, because with contact lens, the image magnification and the field problems are less. They are less but not completely gone. So best is intraocular lens. Okay. So this is all which can be like, asked in aphakia. What is aphakia? What happens with the aphakic glasses? And what is the best correction with the aphakia? Okay, so we have done that. Is that all right? Okay, then moving on to the correction of the refractive error, beta. Now, in the correction of the refractive error, in your last exam only, there was a question that how would you get the glass prescription from a retinoscopy finding? Okay, so retinoscopy finding is when you are determining the refractive error, but how would you prescribe the glasses from the retinoscopy? So to prescribe the glasses from the retinoscopy, we have to do certain calculations. So what we do, so first of all you check, as I told you, you always check on both the meridian. So you will check the refractive error at both meridian, both principal meridian. Okay, so first step is you check both horizontal, which is taken as your 180-degree meridian, and vertical, which is taken as your 90-degree meridian. So you check the refractive error at both the meridian, what it is. Then once you have checked that what is the refractive error, to get a glass prescription from that, because in retinoscopy you are checking at a distance, so that is known as working distance. So you have to subtract the working distance. So you do the subtraction of working distance, which is usually, it will be given in your case statement. Usually they give a working distance of 1 meter. So if they give a working distance of 1 meter, you will subtract -1 diopter from the correction which you have taken. I will show you an example so that you remember how to do this. Okay. And if cycloplegia was used, for example in children, then you subtract the cycloplegia also. So the correction has to be applied for the cycloplegia also. So mostly it is done under atropine. So if it is done under atropine, then we subtract -1 diopter again. Okay. So these are the three things which we do when you want to convert a retinoscopy finding into glass prescription. So first you will check what is there in both meridian, horizontal and vertical. For working distance, if it is 1 meter, you will subtract -1 diopter. And for the subtraction of cycloplegia, for atropine, remember, you subtract -1 diopter. So these are the conditions which are usually given. Okay. So let's go for an example. And if in your exam they give you a power cross like this, and they tell you that, in the vertical meridian, in the 90-degree meridian, the correction which was found on retinoscopy was +3. The error which was found on the retinoscopy was +3. Okay. And in the horizontal meridian, they found again +3. So both are same. It means there is no astigmatism. But now how will you convert it into glass power? So please listen clearly. So if they say the retinoscopy was done at 1 meter working distance under atropine, 1 meter working distance under atropine, then I have to subtract -1 for the working distance and -1 for the atropine. Similarly, from horizontal meridian also, I subtract -1 from the for the working distance and -1 for the atropine. So my corrected cross will be, +1 diopter and +1 diopter, because I have subtracted -2 here. So my glass prescription will be, so it is same at both 90 and 180 degree. So it will be a spherical correction. It will be a spherical correction beta, and it will be written as +1 diopter sphere. It will be written as +1 diopter sphere. Okay, right? Now, supposedly it is not same at both the meridians. Supposedly it is not same at both the meridian. So, what it is? So, supposedly at one meridian it is +5, at other meridian it is +3. So, vertical +5, horizontal +3. After subtraction, the corrected cross, same conditions, 1 meter distance under atropine. After correction, it becomes +3 and +1. Okay, right? After correction. Now, if you see here, this is a case of astigmatism. This is a case of astigmatism, that at one point it is +3 and at the other point it is +1. So, what do we do here? So, here you have to give both the spherical as well as the cylindrical glass. And here, how do I choose? I choose the smaller power as sphere. Okay, I choose the smaller power as sphere. So, I give +1 diopter sphere. Okay, so with +1 diopter sphere, the 180 degree meridian is completely corrected. Okay, and what is the residual here? What is the residual at the 90 degree meridian? +2. +2 is the residual at 90 degree meridian. Okay, so I have to give +2 diopter cylindrical. +2 diopter cylindrical. But now, an important point to remember. Okay, according to the optics, the cylindrical lens, if I place the cylindrical lens at 180 degree, its effect will be at 90 degree. Okay, please listen carefully, friends. If you place cylindrical lens at 180 degree, it is actually acting at 90 degree. Right? If you place that at 90 degree, it acts at 180 degree. So, it acts 90 degree to where you place it. So, now here in this situation, where do I want the cylinder to act? Friends, where do I want the cylinder to act? I want the cylinder to act at 90 degree. So, where should I place it? Where should I place it? I should place it at 180 degree. Okay, so this will be the complete correction for this patient. +1 diopter sphere, +2 diopter cylindrical at 180 degree, because that will act at 90 degree and that will bring about the correction there. Okay, so please remember once again, wherever you want the cylindrical power to act, place the cylinder at 90 degree to that axis. So, if you want the action to be at 90 degree, it will be placed at 180 degree. Okay, right? Right. So, this was your question in the last year exam, beta, how to convert the retinoscopy into glass power. So, please remember this. Please try to solve it by putting different powers. Try to practice it. Okay. Then another thing which is sometimes asked in your exam is the spherical equivalent. Spherical equivalent. Now, what is this spherical equivalent, friends, or where it is used? So, sometimes what happens, a patient has an astigmatic error. So, that is why he needs cylindrical glasses. But he is not comfortable to wear the cylindrical glasses. They do not wish to wear the cylindrical glasses. So, what is the option there? So, this is, in this situation, you can give spherical equivalent, that only spherical power is given. But of course, you cannot, like, just forget about the cylindrical glass. So you have to convert the cylindrical power into spherical equivalent, and there is a formula for that. What is the formula? Formula is you take the spherical power, whatever is there, and you add half of the cylindrical power to that. So now the patient will be wearing only spherical glasses with equivalent added for the cylindrical power. Okay. So how the question is asked in this? The question is asked that the patient is not happy or patient does not want to wear the astigmatic glasses. So what will be the best option? The best and the easiest option will be to use the spherical equivalent. And how you will calculate the spherical equivalent? Supposedly the patient is having +3 diopter and +2 diopter cylindrical, okay, at 90 degree. So what will be the spherical equivalent for this? The spherical equivalent will be +3 diopter, the total spherical power, plus half of the cylindrical power, that is +1 diopter. So the spherical equivalent becomes +4 diopter. So you will give, rather than giving this prescription to the patient, you can try +4 diopter, which is the spherical equivalent. Okay, right? So this, if any question comes about spherical equivalent, now you know that this is when the patient, they do not want to wear cylindrical glasses, and this is a formula for the spherical equivalent. Okay. Now something about the contact lenses, beta. Something about the contact lenses. Contact lenses is another way to correct the refractive error. Okay, where would you use the contact lenses? Okay, where would you use the contact lenses? Supposedly the patient wants it for the cosmetic purposes, that they do not want to wear the glasses, like, you know, they don't like that there should be glasses on their face. You can use the contact lenses. Okay, then another use of the contact lenses is, as we just read, in the cases of astigmatism, especially irregular astigmatism. For irregular astigmatism, the contact lenses are the better choice. Okay, so this can be asked as a one-liner question also, beta. For example, in a case of corneal opacity, in cases of early keratoconus, irregular astigmatism. So please remember, contact lenses are the better choice for irregular astigmatism. Okay, similarly, in the cases of aphakia, as I told you, because they cause less magnification. In the cases of anisometropia. So what is anisometropia, dear friends? So if you remember, anisometropia is when there is significant difference between the refractive error of the two eyes. When there is significant difference in refractive error of the two eyes. So again, your one-liner question, in refractive error of two eyes. For example, one eye is -5 diopter, other eye is -3 diopter. A patient will be more happy if you give contact lenses rather than giving the glasses. Okay, so these are the few indications where contact lenses are preferred. Irregular astigmatism over the glasses, okay, preferred over the glasses. Irregular astigmatism, aphakia, anisometropia. Okay, and what are the disadvantages of the contact lenses? There are two main disadvantages. We'll be touching upon them once more also, but please note it down here also. One is contact lenses can cause allergic conjunctivitis, what is known as GPC. So we'll be talking about just after a while giant papillary conjunctivitis. They can cause giant papillary conjunctivitis. And the second is they can cause corneal ulcer. They can cause corneal ulcer, specifically most commonly pseudomonas. Okay, so these are the two risk factors. Not every case, please don't think that every case there will be corneal ulcer or GPC, but risk is there. Okay, so this is about contact lenses. Now in the last part which you should know is besides glasses, beside contact lenses, what else is done for the refractive correction? So we have refractive surgeries, as you know. The important ones which you should know is number one, your LASIK. Okay, LASIK is laser assisted in situ keratomiliosis. I'll just describe a bit more about it. Okay, then the second type is RELAX or the SMILE procedure. Okay, in which there is no flap, no corneal flap is made. Okay, so SMILE is a small lenticule of the cornea. Small lenticule extraction is done. Okay, a small part of the cornea is removed, that is SMILE, and no flap is needed. Okay, and the third is, what you should know is what is known as phakic IOL. Phakic IOL, which is also called as ICL. So what is ICL? It is implantable columnar lens. Implantable columnar lens. So phakic means the natural lens is also there, beta. The natural lens is also there, and in addition an extra lens is placed over that to correct the refractive error. Okay, so these are the three procedures which are done nowadays. LASIK, I'll just tell you about LASIK a bit more because it's important for exam. Then SMILE, in which no corneal flap is raised, a small lenticule of the cornea is removed. And the third option is you put a phakic IOL, which is known as implantable columnar lens. In cataract surgery, you remove the cataract and then put an IOL. In phakic IOL, you do not remove the natural lens, you put an extra lens inside the eye. Okay, so have a concept like that. Now about the LASIK, friends, you should know just the basic of LASIK. So this figure will tell you about that. In LASIK, we have to remove a flap of the cornea. We have to remove a flap of the cornea, as you see here. So you remove the flap of the cornea and then you apply laser on the base. And then you apply laser on the base. The laser which is applied here is your excimer laser. The laser which is applied for the ablation of the cornea is the excimer laser. Okay, and then once the laser is done, the flap is repositioned back. Okay, so in LASIK, remember, a corneal flap is to be raised. The laser is applied on the base for the ablation of the corneal tissue, which will bring about the changes in the corneal curvature, and that will correct the refractive error. Okay. Now in LASIK, the few things which we should remember is what are the indications and contraindications. So that can be your question, beta. The absolute contraindications, they include keratoconus. You will never do LASIK for keratoconus. So keratoconus is a contraindication for, it's a contraindication for LASIK. Okay. Similarly, then if there is unstable refractive error, the refractive error is not yet stable, you will not do the LASIK. You will first try to stabilize the refractive error. Okay. Then if the corneal thickness is less than 450 microns, the LASIK is not preferred. And lastly, the age should be more than equal to 21 years. Okay, so these three things, they can be asked in your exam, beta. For LASIK to be done, first, refractive error should be stable. The corneal thickness should be more than 450 micron. If it is less than 450 micron, the LASIK is not done. The age should be more than equal to 21 years. And keratoconus is a kind of absolute contraindication. You do not do LASIK for keratoconus. Okay, so please remember. So these were the points which were needed some understanding, and the high yield points, because lately the questions, they have been asked from the refractive error part quite a bit. Okay. Now we move forward beta, and now we'll be discussing the important topics for conjunctiva, the different important diseases of conjunctiva. Okay, so shall we go ahead? Okay, so in conjunctiva, again the first topic which I am going to discuss is your trachoma. Trachoma, an important one for your exam beta, trachoma. So first of all, we should know the trachoma is caused by which organism? It is caused by Chlamydia trachomatis. Now there are different serotypes of chlamydia. The serotype A, B, BA and C, easy to remember, AB, BA, C. So these are the serotypes which cause trachoma. So here only I have mentioned there are another serotypes which are like serotypes D to K. They cause a different type of conjunctivitis, what is known as adult inclusion conjunctivitis. Adult inclusion conjunctivitis, or what is also known as swimming pool conjunctivitis. So the name suggests swimming pool, when you are sharing the public pools, so infection goes from one person to another person. So if they are asking about the cause of swimming pool conjunctivitis or adult inclusion conjunctivitis, then it is serotypes D to K. Then there is another virus which causes swimming pool conjunctivitis. So another cause of the swimming pool conjunctivitis is your adenovirus, right? So here we have covered 2-3 one-liner questions. Trachoma is caused by Chlamydia trachomatis serotype A, B, BA and C, and then what are the causes of swimming pool conjunctivitis. Okay, now something more about trachoma. Now in trachoma you have to remember what are the typical clinical signs. Now trachoma usually is a chronic conjunctivitis seen in children, and then from the children it can spread of course to the elderly. Okay, there are typical signs which are seen in trachoma. So one is known as what is called as sago grain follicles. Okay, sago grain follicles. So sago grain follicles, as you see in this image, they are large follicles. Okay, so in trachoma, please remember, you see follicles. In trachoma, you see follicles and they are large sized. So this can be asked as an image question also beta. This can be asked as an image question. So if on the upper tarsal conjunctiva, upper palpebral conjunctiva, there are these large sized follicles. The follicles, how would you identify the follicles? They, as you see here, they appear yellowish raised lesions like sago grains. They appear as yellowish raised lesions as sago grains. So this is your trachoma. This is trachoma. Sago grain follicles are seen in trachoma. Okay. Then what else can be there? If these follicles, they are present at the limbus, then they are known as Herbert follicles. Okay. So in the conjunctiva, they are like sago grains. If they are present in the limbal area, they are called as Herbert follicles. Now trachoma has different stages. You will see the follicles in the active stage, but when it regresses, it goes into the fibrotic stage. The Herbert follicles, they form Herbert pits. The Herbert follicles, they form Herbert pits as you are seeing here. So Herbert pits are these kind of depressions in the limbal area. Pit means a depression. Okay. So in the active stage you will see Herbert follicles, and in the healing stage you will see Herbert pit. Another sign which is seen in trachoma is Art's line. Art's line. So what is Art's line? It's a kind of a fibrotic line, as you notice here in the subtarsal conjunctiva again because of fibrosis. Okay, so these are the typical signs. They can be asked as one-liner question also, or they can be asked in the clinical case statement. Sago grain follicles, friends, Herbert follicles, Herbert pits in the healing stage, and Art's line as subtarsal fibrosis. Okay, now in the trachoma, another thing which is often asked in your exam is, because trachoma is, it becomes an endemic disease. It spreads from person to person. Okay. So for the control of trachoma, the WHO, especially for in the endemic areas, they have advised a strategy to eliminate that, what is known as SAFE strategy. Now the questions they have been asked upon this SAFE strategy, very important. So what are the components of the SAFE strategy? Important to know. The question has been asked upon that also, beta. In the SAFE strategy, the S means surgery. Surgery, because in trachoma there can be complications of tracheasis, entropion. So to correct those, the surgery is done. Okay. Then A stands for antibiotics. So what are the antibiotics of the choice in trachoma? Now for the eradication of the trachoma or for elimination of trachoma, the antibiotic of the choice is erythromycin. Erythromycin, the single dose erythromycin is given as a part of the SAFE strategy. Okay. The F stands for beta facial cleanliness. Facial cleanliness, because the flies, they act as a vector for the disease. So from a person they take the discharge and they go to other person and they spread the infection, right? Okay. So facial cleanliness. And E stands for environmental improvement to reduce the transmission. So SAFE strategy, again I am stressing upon, is for the control of trachoma. What are the four components? Surgery, antibiotic, facial cleanliness and environmental improvement. And what is the drug of the choice? Azithromycin. So all these are your questions, beta. All these are your questions for trachoma. Okay, right? Now moving ahead to another condition, another infective conjunctivitis, what is known as ophthalmia neonatorum. Ophthalmia neonatorum. So what is ophthalmia neonatorum? It is a conjunctivitis which is seen in a neonate. Neonate means a baby within 28 days of the life. So if there is any discharge in a neonate, that is considered to be pathological. So you see here this picture, this can come as an image question also, beta. This can come as an image question. So if you see the discharge, very easy to identify. You see this discharge, the matting of the lashes, the stickiness of the eyes. In a neonate, of course, they will be telling you that this is a neonate, this is the image. So your diagnosis will be ophthalmia neonatorum. Now in ophthalmia neonatorum, there can be different reasons for the conjunctivitis to occur. And what are the important ones, beta? It is divided into due to chemical reasons. So chemical causes, they appear very early. Which chemical causes ophthalmia neonatorum? It is silver nitrate. Silver nitrate. So silver nitrate drops were used to prevent or prophylaxis of ophthalmia neonatorum in the early days. Okay. So now it is not used. Now it is not used. But if you put silver nitrate to a newborn's eye, it can cause chemical conjunctivitis within hours, right? So silver nitrate used to be the cause of chemical conjunctivitis. Then gonococcal infection. The gonococcal infection from the mother can cause conjunctivitis to the baby. The gonococcal usually appears within 1 to 4 days of the birth. Then another one is your chlamydia. Okay. Chlamydia appears within 5 to 14 days. Then other bacterial specific, mostly Staph aureus, that is usually after 1 week. And then there can be the viral due to herpetic infection, herpes simplex, which occurs little later, that is after 1 to 2 weeks. Okay. So all these, they can be causes of your ophthalmia neonatorum. Now here what you need to remember further is chlamydia is the most common. Okay. So please remember chlamydia is the most common. And gonococcal is the most dangerous. Gonococcal is the most dangerous. Why? Because it can cause corneal ulceration. So gonococcal conjunctivitis in a case of ophthalmia neonatorum is most dangerous because it can cause corneal ulcer, right? So what is the importance of identifying? Because you will give the treatment accordingly. Na? If it is gonococcal, you will give topical as well as systemic antibiotic. If it is herpes simplex, you will give antiviral. If it is chlamydia, you can give tetracycline ointment. So that is why you need to identify which is the type. And what is the prophylaxis for ophthalmia neonatorum? So for prophylaxis, nowadays we use povidone iodine. We use povidone iodine. Again, important to remember, beta. For ophthalmia neonatorum, we use povidone iodine for the prophylaxis. Okay, right? So ophthalmia neonatorum, please remember the image, the causes, which is the most dangerous, which is the most common, and prophylaxis. Now, regarding COVID-19 infection and conjunctiva, so again the question is coming, and that is what is most common eye symptom also. So if a person has COVID-19 in the eye, the most common eye involvement is conjunctivitis, beta. Okay. Now it can be involvement of anything. It can cause uveitis, episcleritis, it can cause posterior uveitis, it can cause vein occlusions, optic neuritis. So anything can happen, but please remember the most common ocular symptom of COVID-19 infection is conjunctivitis. And what is COVID-19? It is a virus. So viruses, they cause follicular conjunctivitis. Okay. So just two things to remember about COVID-19 infection in the eye. Most common symptom is conjunctivitis. Which type of the conjunctivitis? Follicular conjunctivitis. Okay. COVID-19, follicular conjunctivitis. Okay, beta, right? Now, after this, I am going to move another often favorite topic of the examiners, vernal keratoconjunctivitis. Vernal keratoconjunctivitis. Now, vernal keratoconjunctivitis, another name for this is, as you know, spring catarrh. Spring catarrh. Now, this can be asked as an image-based question as well as clinical case. Now, in clinical case scenario, what will be there, beta? So, please remember, there will be a history of child, mostly boy, okay. So, something like maybe 5-year-old boy, because it is considered to be more common in male child, okay, complaining of itching of the eyes, ropey discharge or mucoid discharge, which is more in the summer season. So these are the points. Please remember, a boy, usually age group of 5, 6, 7 years old, with itching, with ropey discharge, and the symptoms which are worse in summer, and they can be associated with some other allergic symptoms, for example running nose, allergic rhinitis, etc., because it's an allergic type of the conjunctivitis. So if this is the scenario, then most likely it is vernal keratoconjunctivitis or spring catarrh. Okay. And if they show you the image, in the image mostly they show you the image of the papillae. So what you are seeing over here, my friends, are the large papillae, which we call as giant papillae. So there can be giant papillae or there can be normal papillae also. So if you see papillae, so papillae, how to identify from the follicles? These are reddish and they are flat topped. The follicles, they were round and they were yellowish. So if this is the image, along with the features of itching, ropey discharge, summer season aggravation, then that is a case of spring catarrh. Beta, please don't forget this. This is often asked question and very easy question. Vernal keratoconjunctivitis. Okay, what else can be there? So in vernal keratoconjunctivitis, as I told you, it's an allergic disease. Type 1 hypersensitivity, patient presenting with itching with ropey discharge. When there are giant papillae, they give an appearance of cobblestone. So it is also called as cobblestone appearance of the conjunctiva. Then another feature which you will see, they can ask as a question, is Horner Tranta spots. So see here, these are your Horner Tranta spots, the papillae around the limbus. So Horner Tranta spots again feature of VKC or vernal keratoconjunctivitis. Okay. What else? If there is a complication and ulcer on the cornea, that is called as shield ulcer. Okay. So another complication of the VKC can be formation of shield ulcer, and sometimes there is the formation of pseudogerontoxon, or also called as cupid bow. So what it is like, in the recurrent cases, you see a kind of opacity on the cornea, opacity on the peripheral cornea like this, which is called as cupid bow. So just remember the name. Okay. So these are the signs associated with VKC, right? Cobblestone appearance of the conjunctiva if there are giant papillae, Horner Tranta spots, shield ulcer, pseudogerontoxon or cupid bow. And I already told you in clinical case scenario, don't forget a young boy, summer season aggravation, itching, ropey mucoid discharge and other allergic features like rhinitis or watering, etc. So that will be a case of VKC. Okay, right? Now a similar condition in which again you see giant papillae. So here you will always see giant papillae. So that is why the name is giant papillary conjunctivitis. But giant papillary conjunctivitis is usually associated with, as I already told you, with the contact lens use. So now if there is a history, so please listen carefully beta, if there is a history, so contact lenses are usually used by adult or adolescent people. So if there is a history that there is 20-year-old girl who is a contact lens user and she is having itching, redness of the eye, and you see giant papillae or cobblestone appearance. So cobblestone appearance can be seen in GPC also. So cobblestone appearance is due to the giant papillae. So that can be seen in GPC also. So then it is giant papillary conjunctivitis. So please differentiate between VKC and giant papillary. VKC is the allergic condition in young boys, more in summer season. Giant papillary conjunctivitis is with the contact lens use. So if there is contact lens use, remember giant papillary conjunctivitis. Okay. So here again, as I tell you, the same image, it can also be there with the image based question, but of course they will tell you that there is history of use of contact lenses. Okay friends, right? Okay. Then in the conjunctival conditions, another thing which we want to know is what is called as phyllectanular conjunctivitis. Now this is a type 4 hypersensitivity reaction. Okay. To what? Usually to two antigens. One is your tubercular antigen or to the staph infection in the body. Okay. So because of the type 4 hypersensitivity reaction, there is formation of these yellowish nodules at the limbus. These nodules beta are called phyllectons. Okay. So if there are yellowish nodules at the limbus, what you are seeing here, then it is a case of phyllectanular conjunctivitis, which is due to type 4 hypersensitivity reaction mostly to tubercular antigen, because in India the tuberculosis is endemic, and or it can be even to staph infection. And in some cases, if cornea gets involved, then it leads to the formation of fascicular ulcer. So they can ask you a one-liner question. The fascicular ulcer is seen in phyllectanular conjunctivitis. Okay, so what we discussed VKC, giant papillary conjunctivitis, and phyllectanular conjunctivitis. Okay, friends, right? Then another important condition which can cause symptoms in the cornea as well as in the conjunctiva, asked in your last exam, what is known as xerophthalmia. So I'll be discussing it here at the moment, xerophthalmia. So what is xerophthalmia, beta? The xerophthalmia is the signs and the symptoms which you see in the eye due to vitamin A deficiency. Okay, so first of all, you should know what causes the xerophthalmia. Vitamin A deficiency. Vitamin A deficiency. Okay, so they can ask you about all these features, and they can ask you which vitamin deficiency causes bitter spot, conjunctival xerosis, or corneal ulceration, which is known as keratomalacia. So please remember, these are the features of vitamin A deficiency. Okay, so depending upon the different stages, different signs are seen. So please look at this chart here, beta. So first is night blindness. So that is the first symptom. It is the first symptom of vitamin A deficiency. Please remember, night blindness, which is also known as nyctalopia, is the first symptom of vitamin A deficiency. Okay, friends, and conjunctival xerosis. Conjunctival xerosis is first sign of vitamin A deficiency. And what is xerosis? Xerosis means, beta, dryness. Dryness. The conjunctiva, see, normally you see how the eyes are shining, they are lustrous, because it is covered by a good tear film. If the eye becomes dry, it becomes like, the surface loses its luster. So that is the first sign. The conjunctiva starts appearing dry. Then there is a formation of bited spots. Bited spots. I'll just show you the figure. Then this comes the stage which is called as X2, when the cornea also becomes dry. Okay, so bited spot, and then cornea also becomes dry, which is known as corneal xerosis. And whenever there is a dryness of the cornea surface is not healthy, there is always risk of ulcer formation. And the corneal ulceration, which occurs in vitamin A deficiency, is very, very severe. It is also known as keratomalacia. Keratomalacia. So that is another term which is used for the corneal ulceration in cases of vitamin A deficiency. Okay, so depending upon whether less than 1/3 of the cornea is involved, the stage is X3A. If it is more than 1/3 of the cornea is involved, the stage is X3B. So once the cornea is sloughed off, it will be replaced by a scar tissue. So that is corneal scar. And not only in the conjunctiva and in the cornea, the changes they occur in retina also, so which is known as xerophthalmic fundus. So there are pigmentary changes on the retina. Pigmentary changes on the retina. Okay, so this is again important, beta. I am highlighting it once more. The question was there in your last exam also. So xerophthalmia, please remember all the features of xerophthalmia. Conjunctival xerosis, bited spot, corneal xerosis. Xerosis means dryness. So they can ask you, they can give you a case scenario also. Okay, so they can give you a case scenario also, that a mother brings a child who is complaining of difficulty of vision in dim light. So night blindness means that in dim light also. and there is dryness of the eye. So what is the most likely diagnosis? So dryness of the eye means xerosis along with night blindness. So that should tell you that this may be a case of vitamin A deficiency. Vitamin A deficiency. Okay. And then they can show you this image also. So again an important beta. This can be your image based question also. So what you are seeing here, do you notice here? A white foamy spot. A white foamy spot on the conjunctiva, usually on temporal conjunctiva, temporal bulbar conjunctiva. A white foamy spot on temporal bulbar conjunctiva. This is your bited spot which is seen in vitamin A deficiency. So please remember all these words and please remember this image. So the image can be shown with the case also, that there is a child with night blindness and this is what is seen on examination. There is a dryness of the eyes. What is your diagnosis? So your diagnosis is very straightforward. It is vitamin A deficiency. Okay, so I hope you will not forget this. Fine, right? So bited spot, please remember the image, please remember the cause, and as I told you, remember all the features of xerophthalmia. Remember all the features of xerophthalmia, friends. Okay, right? Fine. So let's move to another favorite topic of the examiners. Let's move to another favorite topic of the examiner. So see this image, friends. This is almost a spot diagnosis. See this image. This is almost a spot diagnosis. So what do you see here? What do you see here? You are seeing that there is this fold. There is this triangular kind of fold of the conjunctiva which is encroaching upon the cornea, isn't it? A fold of conjunctiva encroaching upon the cornea. So what is this? This is pterygium. So again another image which you should make, like, you know, absolutely imprinted on your mind. Pterygium. When you see a fold of conjunctiva, usually from the nasal side, coming encroaching upon the cornea, this is pterygium. You see, it's a kind of fleshy kind of growth, a fleshy kind of growth. This is your pterygium. Okay, let's revise something more about pterygium. So what it is actually, it's a type of a elastotic, that is, there is hypertrophy also, as well as the degenerative changes which cause this growth over the cornea. Okay, the risk factor, one risk factor is ultraviolet rays. Similarly, dusty environment. Okay, so it will be more common in people who are more on outdoors in dusty environment, farmers, field workers. Okay, so the risk factors. Then if you see the shape of the pterygium, you can divide it into, like, you know, the body, neck and head of the pterygium. So this part is called as the body. Then in the middle is the neck of the pterygium and the moving edge is called as the head of the pterygium. Okay, then sometimes there is a deposition of the iron, in the cornea just ahead of the head of the pterygium, what is known as Stocker's line. So there can be deposition, you can see something like this, there can be deposition of the iron, what can be called as Stocker's line. Okay, so what is Stocker's line? It is an iron deposition. They can ask as a one-liner question. Iron deposit in the cornea just in front of head of pterygium, that is Stocker's line, right? So how we will treat this? So the treatment is, like, you know, why we need to treat this? Because it is moving. Number one, it can be cosmetic problem. Okay. Number two, it can cause astigmatism because it is encroaching on the cornea. It can affect the curvature of the cornea. Okay. And when it is covering the pupillary area, see here it is covering the pupillary area. So if the central pupillary area is covered, the vision will be blocked. So then you need to treat it. So the treatment is in the form of excision, that you surgically remove it. But if you just remove it, there is high chance of recurrence. So to prevent the recurrence, we can do three things. To prevent the recurrence, we can do three things. We can excise and then use mitomycin C, MMC. We can use mitomycin C. Okay. The second is we remove and we put an autograft of the conjunctiva, conjunctival autograft, so that there is no recurrence. Okay. The third thing is you can use amniotic membrane graft. Okay. So amniotic membrane is harvested in the form of a graft and then it can be used here. Okay. So all these, they prevent recurrence. All these, they prevent recurrence. Then there is always a question, which is the best? Okay. Which is the best method? Which is the best method? So if you have to choose the best method, friends, it is conjunctival autograft. Okay. So conjunctival autograft will be best out of these because mitomycin has its own complication. Amniotic membrane is not available everywhere. Conjunctiva, it's in the same eye of the patient, or you can take even from the other eye. So autograft, the patient's own graft. So that is the best. So that is where they often ask the question also, beta. They often ask the question, what is the best treatment or ideal treatment for a recurrent pterygium or to prevent the recurrence of a pterygium? That is conjunctival autograft. Okay. So pterygium, the treatment question is usually asked, beta. And you can always identify, if it is the image, you can always identify, as I told you, by this triangular fold of conjunctiva covering the cornea. Okay, right? Are we good here? Okay, fine. So that was what we should know and what we just not miss in the conjunctiva. Few very important, easy to learn topics and often repeated topics, beta. Okay. So now I am coming to the cornea part. Again, a very favorite with the examiner. In every exam, you will get one or two questions minimum from the corneal conditions. So please be with me, be attentive, be there, and let's see what we need to know about the cornea, the high yield points. Okay. Let's revise, beta. So in the cornea, just let's revise this figure here. So in this figure, this is telling you the different layers of the cornea, beta, for the quick revision. So cornea, as you know, is a multi-layered structures. We define it as having 6 layers. So as you notice here, the top one is epithelium, and as you notice, the epithelium is multi-layered structures, stratified, non-keratinized, squamous epithelium. Okay, stratified, non-keratinized, squamous epithelium. Okay, then there is your Bowman layer. Bowman layer is not a true membrane, and Bowman layer cannot regenerate. These points are written, don't worry, I'll be showing you the slide. Okay, then comes your stroma. So as you can see, the stroma is the thickest part, and the stroma has different collagen fibers. So these fibers are arranged in a regular manner and they are responsible for the corneal transparency. Then is your Duas layer. Okay, then is your Duas layer. This Duas layer is a newly defined layer. It is present just in front of the descemet membrane. It is present just in front of the descemet membrane. And now Dua's layer is considered to be the most tough layer. Descemet membrane is the most elastic layer, and it is a true membrane. It is a true membrane. And then comes most posterior is your endothelium. Okay, so as you see, the endothelium is a single layered. Okay, so it has uniform hexagonal cells in the form of a single layer. And endothelium is the one which is most important for maintaining the hydration of the cornea. Hydration of the cornea. Okay, so this picture, if you have in mind, so that tells you about the different layers of the cornea. And let's go through the important points once more, which we should know about the different layers of the cornea. So the latest corneal layer discovered, as I told you, is Dua's layer. Most metabolically active layer of the cornea is endothelium. Similarly, the layer which is maximally responsible for the corneal hydration, because if the corneal hydration is not maintained at the normal level, the cornea becomes edematous. It loses its transparency. So again, the most important layer is endothelium, because it has sodium, potassium, ATPase pump. It has sodium, potassium, ATPase pump. The Bowman layer cannot regenerate, please remember. Descemet membrane is most elastic layer, and Dua's layer is the toughest layer. Okay, Dua's layer is the toughest layer. Fine, right? Okay. Then in endothelial cells, the normal shape of the endothelial cells is hexagonal cells beta. They are hexagonal in shape. Okay. Already told you sodium, potassium, ATPase pump is present in the endothelium. The normal endothelial cell count is about 3000 to 3500 cells per millimeter square in adults. Okay, and this count is important because if the count goes below certain level, which level? If it goes below 500 cells per millimeter square, then there is permanent corneal decompensation. So what is permanent corneal decompensation? That the cornea becomes hydrated, it loses its transparency. Okay, so please remember these few points which they can ask as one-liner question in your exam regarding different corneal layers. Endothelial cells, the normal shape and number of the cells is important to maintain corneal transparency. Okay. Then few investigation methods related for the examination of the cornea. Again, they can be asked as one-liner question. What is pachymetry? Pachymetry is measurement of corneal thickness. What is keratometry? It is measurement of corneal curvature. But keratometry gives me only central corneal curvature. Only central corneal curvature. If I want to know the curvature of all of the cornea, what is called as mapping of the cornea, along with the thickness of the cornea, I can get that done by corneal tomography. Corneal tomography. Okay, so that gives me curvature of whole of cornea, anterior as well as posterior surface, along with the thickness beta. And then there is an investigation, please remember, specular microscopy, which gives me the endothelial cell count as well as morphology. So to study the corneal endothelium, the investigation which is done is specular microscopy. Okay, so these investigations, please remember, for different corneal diseases, right? Now, we are moving on to a very important topic, that is the corneal ulcers beta. Different type of the corneal ulcers. Again, very important for the exam. They can show you the image, they can ask you the clinical case scenario. So please have your full attention here for corneal ulcers. And for the corneal ulcers, first of all, we are going to discuss the bacterial corneal ulcers. Okay, so different infections, they can cause corneal ulcers, as you know, bacteria, fungal, viral, protozoal. So let's start with the bacterial. Now in bacterial, the most common risk factor, because there has to be some risk factor, not everybody is going to develop the ulcer fortunately. So there are certain risk factors which lead to the ulcer formation. So in developed countries, the contact lens use is considered to be the most common risk factor. But like in India, the trauma due to anything, even the rubbing of the eyes, that can cause the corneal ulcer. Okay. Now in corneal ulcer, please always remember these 5 clinical features. So very, very important. Please remember these 5 clinical features. If in the history there is pain, okay, redness of the eyes, discharge, photophobia, and decreased vision. Okay, so painful decrease in vision, red eye, photophobia, discharge, then there is always a chance of the case is of corneal ulcer. Okay, because in conjunctivitis, redness can be there, but there is usually no decrease in the vision. Discharge can be there, but usually there is just mild discomfort, not pain. So you have to differentiate the red eye of conjunctivitis from corneal ulcer. So in corneal ulcer, please remember these 5 clinical features: photophobia, redness, painful decrease in the vision, discharge from the eye. Okay, and please remember the most common organism is pneumococcus. Specifically for India, worldwide they can say Staph aureus. If nothing is mentioned, you can mark pneumococcus. Okay, so trauma and pneumococcal infection is the commonest for general, if there is nothing mentioned there, for bacterial corneal ulcers. Okay, so how the bacterial corneal ulcer looks like? So whenever there is an ulcer, there is abrasion of the epithelium, there is infiltration of the cornea. Okay, now in bacterial corneal ulcer, as you can see in this figure, you will see there is red eye, of course. Okay, but you will see the infiltrates, they are kind of what we call as moist. Okay, and they are well defined. So as you can see, the ulcer is well defined, right? There can be hypopyon. This is the hypopyon. Hypopyon means pus cells in the interior chamber. But the hypopyon in the case of bacterial corneal ulcer is sterile. Sterile means it does not contain any bacterial element, no bacteria, only pus cells, and it is mobile. Okay, there is always, like, vascularization, early vascularization, the vessels coming on the cornea in the bacterial ulcer, and the risk of the perforation, that because there is necrosis or sloughing of the corneal tissue, the perforation is very common in bacterial ulcers, right? So these are the features of bacterial corneal ulcers: wet infiltrate, well defined ulcer margins, sterile, mobile hypopyon, early vascularization, and perforation. Why we need to know this? Because you have to differentiate it from the other type of the corneal ulcers, right? In bacterial corneal ulcer, my dear friends, remember 2 more things. What is known as hypopyon ulcer or Serpens ulcer. Hypopyon ulcer or serpent ulcer, that is ulcer like a serpentine fashion, it moves. Now it is caused by pneumococcus. It is caused by pneumococcus beta. Okay, so this can be asked as a question. The ulcer which is caused by pneumococcus often has hypopion, so it is given the name hypopion ulcer. If they use the word hypopion ulcer, it is pneumococcus. Similarly, serpent ulcer is more common, is caused by pneumococcus. Okay. Then in the bacterial infections, pseudomonas, if the infection or the ulcer is due to pseudomonas, then perforation is very common. Perforation is rapid and common. Okay, because pseudomonas is a very virulent organism. If there is an infection of the cornea by pseudomonas, it can cause very rapid and very commonly it causes the perforation. Okay, so these two are the important bacterial corneal ulcer points. The pneumococcus causes hypopion or serpent ulcer. If there is a perforation, very commonly or rapidly developing perforation, then it is a pseudomonas, most likely the organism, right? Now in the ulcer, like whenever there is corneal involvement in the ulcer, even when the ulcer heals, there are certain changes or sequelae which occur in the cornea. Now these sequelae, what can they be? So they are usually in the form of the scarring or opacity of the cornea. Okay. Now this scarring or the opacity of the cornea, depending upon how much thickness of the cornea is involved, the different type of the opacities they can occur, which can again be like asked in your exam. If there is a superficial opacity beta, as you see here, just less than 1/3 of the cornea, this superficial corneal opacity is called nebular corneal opacity. Nebular corneal opacity, less than 1/3 of the cornea. Okay. If it is more than 1/3 but less than half, as you see here, it is called macular corneal opacity. Macular corneal opacity. Okay. If it is more than half, then the cornea appears whitish. It is called leucomatous corneal opacity. Leucomatous corneal opacity. Okay, friends. And when there was corneal perforation, because different stages can be there, if there is the corneal perforation and afterwards it heals up. So whenever there is a corneal perforation, the iris tissue plugs that area. So this iris becomes adherent. It becomes adherent to cornea. Okay, and then it makes an opacity which is known as adherent leucoma. Adherent leucoma. Okay, so they can be asked as one-liner question, but I have tried to explain it to you with the help of the diagram. Okay. So nebular opacity when less than 1/3 of the cornea is involved. Macular corneal opacity when more than 1/3 but less than half of the cornea is involved. Leucomatous when the cornea becomes whitish and involvement of the thickness is more than half of the cornea. Thickness wise, okay, what I am talking is depth or thickness wise is involved, that is called leucomatous corneal opacity. And what is adherent leucoma? When the iris tissue becomes adherent to the corneal opacity. This occurs when there was a corneal perforation. Then it leads to the formation of adherent leucoma. Okay, right? Okay, so now moving on to another sequelae or a complication which can occur in a case of corneal ulcer beta, what is known as anterior staphyloma. So we discussed posterior staphyloma in pathological myopia. So here it is anterior staphyloma. Anterior staphyloma, staphyloma as I told you is bulging of the eyeball. So this occurs when there is bulging of this corneal tissue and there is an iris tissue incarcerated along with. Okay, so this is again a sequelae of complicated corneal ulcer. This is again a sequelae of complicated corneal ulcer. Now this was asked as an image question in one of the previous exams, beta. So if you see a picture like this, so you know why it happens, because when there was corneal ulcer and it involved leading to the sloughing of the corneal tissue. So there is formation of pseudocornea along with iris incarceration, we know, but this tissue is not strong enough. It is thin, so it bulges forward. So you see the corneal tissue is opaque and it is bulging forward. It is bulging forward. That is called as staphyloma. So they can show you this image and tell you that the patient comes with this image with loss of vision. Usually these kind of things, they happen if the person is malnourished, immunocompromised, that the ulcer was not healing. So this is your anterior staphyloma, which is again one of the sequelae of complicated corneal ulcer. Complicated corneal ulcer. Okay, right? Now moving to the next topic, and then after a while we'll take a short break, beta. Another important topic, again the question where it is asked often, that is your fungal corneal ulcers. Fungal corneal ulcer, again very favorite topic of the examiner. Now in the fungal corneal ulcer, the most commonly it is caused by the filamentous fungi, aspergillus as well as fusarium. In immunocompromised patient, it is the candida infection which is more common. Okay. Now here, one of the very important key points, because fungus infection is always associated with, mostly if it is trauma with the organic or vegetative matter. This is very important point. If in the clinical case scenario, they tell you that there is a farmer who had an injury with a tree twig, with a vegetative matter, with a leaf, then the high chances that it is your fungal corneal ulcer. Okay, there are high chances that it is your fungal corneal ulcer. So please remember this, beta. Trauma with organic or vegetative matter, fungal corneal ulcer. Then the clinical features of fungal corneal ulcer, very important. It can come as an image question also. It can come as an image question also. So what are you seeing here? So here typically the features are, so let's first go through the feature, then I will explain you the image. Here the infiltrates, they are dry looking, they are raised, they have ill-defined margins, and these ill-defined margins are called as feathery margins. These ill-defined margins are called as feathery margins. There will be satellite lesions. I will show you the satellite lesions. The hypopyon is very large and dome-shaped, large dome-shaped hypopyon, which is non-sterile. Non-sterile means it contains the fungal hyphae and it is fixed. It does not move. Vascularization and perforation are uncommon. Okay, but these points, beta, feathery ill-defined margin, satellite lesions are very specific of fungal corneal ulcer. What are the satellite lesions? Like you see here. So this is your main ulcer. This is your main ulcer. You see the margins are not defined. And then these lesions which are away from the ulcer, they are called satellite lesions. Which are away from the main ulcer, they are called satellite lesions. So if they show you this picture that there is a main ulcer and then there are satellite lesions, then it is very typical of fungal ulcer. They can also, mark a lesion and ask you to identify this sign, that there is a main infiltrate area and then there are small infiltrate like satellites, what are known as satellite lesion. So you will mark it as a satellite lesion, beta. So please do remember, injury with vegetative matter, feathery ill-defined margins, satellite lesions, large hypopion, no doubt it is a fungal corneal ulcer. Okay, so please remember that. And coming to the next one, which is your viral keratitis. In viral keratitis, again, few typical points which will be very important to solve the question in exam. Most importantly, if in the history, in the case scenario, they mention that there are reduced corneal sensations. So that is very, very typical of viral infection. Okay. Then in viral infection, they can show you this image also. Now, in this image, beta, what do you see? In this image? So in this image, you are seeing an ulcer. Okay, which is marked by the fluorescent, an ulcer in a dendritic pattern, a typical dendritic pattern. So this is a dendritic corneal ulcer. Which is a feature of herpes simplex keratitis. Okay, so please remember, if they tell you that there is an ulcer with this kind of picture, reduced corneal sensations, you can easily identify by this image. Don't forget this image. This is dendritic keratitis. This is dendritic corneal ulcer, which is caused by herpes simplex, beta. Okay, so a bit more about the herpes simplex infection. Now, herpes simplex infection can involve just the epithelium, when we call it as punctate epithelial keratopathy. Okay, then dendritic ulcer, as I told you, typical of herpes simplex infection. If it worsens, it can lead to the formation of geographic ulcer. I will show you the picture. Sometimes what happens in viral infections, that epithelium is not involved, only stroma is involved. So that is stromal keratitis, or even only endothelium is involved, that is endothelitis, right? And sometimes it causes just immune related disease, that there is no active infection, it's only immune related, then it is known as disciform keratitis. And lastly, sometimes it is a neurotrophic ulcer. Because as I told you, corneal sensations are decreased. So that leads to non-healing of the ulcer, what is known as metaherpetic keratitis. Okay, so what I mean to say is, in viral, especially in herpes simplex infection, it can be active infection, dendritic ulcer or geographic ulcer. It can be immune related disease, what is known as disciform keratitis, and even it can be neurotrophic type of the ulcer due to reduced corneal sensations, what we call as metaherpetic keratitis. Okay, right? So this was herpes simplex keratitis, beta. Don't forget reduced corneal sensations, and don't forget, as I told you, see here in this picture, you are able to see the dendritic ulcer also, right? So here if you notice, the pattern is of dendritic ulcer, and here the pattern is of geographic ulcer. So here it is the geographic ulcer. Here it is the dendritic ulcer. And in disciform, they will not show you the image. This is just to let you know. Here you see it is immune related. You do not see any problem with the epithelium. It is immune related. Okay, right? Fine. So this was the viral keratitis in herpes simplex. Now what is different in herpes zoster? What is different in herpes zoster? For herpes zoster, beta, 2 points to be remembered. Herpes zoster keratitis is more common in immunocompromised patients. It is more common in immunocompromised patients. For example, HIV, patients on chemotherapy, etc. Okay, having malignancies. Then in herpes zoster keratitis, we see a sign which is known as Hutchinson's sign. Or what is called as Hutchinson's rule. What is Hutchinson's rule? It says that if there is vesicular lesions on the tip of the nose, the chances of the involvement of the eye are high due to involvement of the nasociliary nerve. The virus spreads through the nasociliary nerve. If you see lesions on the tip of the nose, they can spread to the eye area. So that is known as Hutchinson's rule or Hutchinson's sign, which is associated with herpes zoster beta. Okay, right? And then in herpes zoster, it is not the true dendritic keratitis. The lesions are pseudodendrites. Pseudodendrite. So they tend to appear as dendritic lesion, but they are not the true dendrite. You can differentiate from the picture there. Okay. So please remember these 2 points about herpes zoster keratitis. They are seen in immunocompromised patients. Hutchinson's rule is seen. Pseudodendritic keratitis is seen. Okay, and then before we go to for a break, 2 points to be remembered. In the treatment part, 2 important points to be remembered. For all the infective corneal ulcers, steroids are contraindicated beta. Steroids are contraindicated. Okay, and in all the corneal ulcers, a cycloplegic is always given, which is usually atropine, besides the other treatment, to relieve the pain, in the corneal ulcer. Okay, so this can be your one-liner question. Okay, so here we take a 20 minutes break beta. We'll be back at 1:30 to continue with our ophtha revision session. Okay, right? So see you in another 20 minutes and join me back for your revision of ophtha. Okay, so I think we can. So welcome back, friends. I hope you had a break and had a chance to eat something, refresh yourself, rejuvenate yourself. Okay, so we'll continue with the corneal ulcer. So I told you all the important points for bacterial, fungal and viral corneal ulcers and the points to be remembered about their treatment, and coming to few more important conditions. So first of all, let's revise something about acanthamoeba keratitis, friends. Now acanthamoeba, as you know, is a protozoa. Okay. So in acanthamoeba keratitis, the infection is usually seen if a person is a contact lens user with poor hygiene, okay, like poor cleansing of the lenses with contaminated water, sharing of the contact lenses, then a person is prone to develop acanthamoeba keratitis. So when you get a question on acanthamoeba keratitis, it can be a case scenario in which they tell you that a person shares the contact lenses with other people, or there is a poor hygiene, poor cleaning of the contact lenses, then a person can develop acanthamoeba keratitis, as I told you. Now, this is a highly painful ulcer. So, that is the most characteristic feature of acanthamoeba keratitis, because due to the involvement of the corneal nerves, the ulcer is very, very painful. We call it as keratoneuritis. So highly painful ulcer. Then a typical shape of the ulcer, what is known as ring shaped ulcer. Ring shaped ulcer. So just to let you know, if you see an image like this, in which the ulcer or the infiltrate, they are in the form of a ring, along with the history of contact lens use, highly painful ulcer. So when this combination of the clinical features is there, my dear friends, then that is a case of acanthamoeba keratitis. Okay, right? Then besides acanthamoeba keratitis, another thing which I would like to revise with you is what is known as Murren's ulcer. Murren's ulcer. So friends, if you remember, Murren's ulcer is a type of peripheral corneal ulcer, that is which starts at the peripheral part of the cornea. Okay, so if you see the image here, again, this is an important image to be remembered. If you see the image here, beta, if you see, you can notice that the ulcer is starting at the peripheral part of the cornea. Peripheral part of the cornea, and a special feature is marked thinning. You notice this thinning of the cornea. This thinning of the cornea like a burrow. Okay, like the rodents, they do burrowing, so they cause thinning of the cornea. So these features are typical of Murren's ulcer, or what, that is why it is also called as rodent ulcer. It starts from the peripheral cornea and it is of autoimmune pathology. It is of autoimmune pathology. It is not infective, right? Then some more non-infective corneal ulcer, and sometimes we get confused also between these two terms. So please concentrate here. There are two conditions. One is known as neuroparalytic keratitis. The other one is known as neurotrophic keratitis. So what is the difference between the two? The difference between the two could be understood by the name. By the name. How? You see, neuroparalytic. Neuroparalytic. So when there is paralysis of a nerve. Okay. So here for neuroparalytic, please remember it is your seventh nerve palsy. Seventh nerve palsy. So when there is seventh nerve palsy, for example, in a case of Bell's palsy, in a Bell's palsy, you remember seventh nerve supplies the orbicularis oculi muscle. So if the orbicularis oculi muscle is paralyzed, you are not able to close your eyes completely. You are not able to close your eyes completely, as you see here. So when the eye is not closed completely, the lower part of the cornea gets exposed, and that leads to exposure keratopathy. That leads to exposure keratopathy. So this type of the ulcer is known as neuroparalytic keratitis. So it is one of the causes of exposure keratopathy, beta. Okay, so how the question they can ask? They can ask the question that there is a patient who is not able to close the eyes completely and part of the cornea is exposed. So what can happen in this case? There can be exposure keratopathy or corneal ulcer. This type of the corneal ulcer is neuroparalytic keratitis, which is due to seventh nerve palsy. Okay. Then the second is your neurotrophic. Neurotrophic. Now, neurotrophic keratitis, the term is used whenever there is ulceration due to decreased corneal sensations. Okay. So here the root cause is decreased corneal sensations, beta. So please don't confuse neuroparalytic with neurotrophic. So whenever there are decreased corneal sensations and there is ulcer formation, that is neurotrophic corneal ulcer or neurotrophic keratitis. And the common causes are fifth nerve palsy due to any reason. It can be acoustic neuroma, it can be stroke, it can be some other cardiovascular, vascular accident, cerebrovascular accident. Okay. So whenever there is fifth nerve palsy, that is the nerve responsible for corneal sensations. So that can lead to neurotrophic keratitis. Then there can be some other causes of reduced corneal sensations. For example, leprosy. So there was a question in the NEET PG based upon this. Leprosy can cause reduced corneal sensation and neurotrophic keratitis. Okay. Even in diabetics, it can cause. Similarly, we already know the viral herpes. They cause neurotrophic keratitis in the form of metaherpetic keratitis. Okay. So neurotrophic and neuroparalytic. For neurotrophic, remember the causes of decreased corneal sensations. Fine. So these were the different type of the corneal ulcers, beta, infective as well as non-infective. Now coming to another important corneal condition in which different questions they can be asked based upon the image, based upon the signs, based upon the case, based upon the treatment. So I hope if you kind of mentally revise, you can identify this condition from these images. So let me show you these two images which can be asked in your exam. So what do you see here, beta? What do you see here? So this is an image which is showing you kind of a side view of the cornea, and you can clearly notice here that the cornea has become conical. The cornea has become conical. So this is a case of keratoconus, in which there is ectasia of the cornea leading on to the conical shape of the cornea. So they can ask the image question showing you this. They can also ask the image question showing you this. So what do you see here? Here the patient is looking down, and as you can see, the lid, the lower lid has become V-shaped. The lower lid has become V-shaped because of the bulging of the cornea. Now this is called Munson sign. Which is again a feature of keratoconus. So either of these two images in which you can make out the conical cornea, or the lower lid is becoming V-shaped when the patient looks down, both these are cases of keratoconus. So let's revise the features of the keratoconus. So in keratoconus, we know because the stroma is becoming thinned out, the corneal curvature is changing. So we see the different signs on the examination. And what are the signs associated with keratoconus? Again, very important topic. We see what is called as Rizzuti sign. Rizzuti sign is due to irregular astigmatism. There is scissoring reflex. When we do retinoscopy checkup, we see scissoring reflex in case of keratoconus. Okay. Then another reflex which we see, what is known as oil droplet reflex. Oil droplet reflex. When we do distant direct ophthalmoscopy, then we see oil droplet reflex. If we do placido disc examination, which is to check the corneal curvature, you will see irregular cornea. Irregular cornea. Right? Then Munson sign, I already showed you. They can show you the image. Then if you check on the slit lamp, you will see thinning of the stroma. Then there is another sign known as Vogue stria. Vogue stria. So these are the stria or the folds which you see in descent membrane. Then in the cases of keratoconus also, the iron can deposit into corneal epithelium, and this deposition is known as Fleischer ring. Fleischer ring, that is the iron ring. Okay, so please remember, these can be asked as one-liner question, or they can ask you as a case scenario that there comes a boy who is not happy with the glasses because irregular astigmatism will not be corrected with the glasses. The patient shows Munson sign, the patient shows stromal thinning on slit lamp examination or scissoring reflex on retinoscopy. What is the diagnosis? So your diagnosis is keratoconus. So please do remember all these signs, my friends. Then another important point about keratoconus is its management. So before the management, sometimes the keratoconus cases, they can further complicate and they can lead to what is known as corneal hydrops. So what is corneal hydrops? This is again a condition which is seen in keratoconus. Why it happens? There is sudden rupture of the descent membrane because cornea is becoming so conical, the descent membrane ruptures and there is fluid which goes inside the cornea. So that is called corneal hydrops. So question can be one-liner, corneal hydrops is seen in the cases of keratoconus. So because of this hydrops, it can lead on to the corneal scarring. So besides the clinical features, what is the investigation of the choice for keratoconus? Investigation of the choice for keratoconus is beta corneal tomography, in which you can measure the corneal curvature of the interior as well as posterior corneal surface and also the thickness of the cornea, corneal tomography. Now treatment of the keratoconus, different treatments are available depending upon the severity or the changes seen in the keratoconus. In the mild cases, we use contact lenses. They are also called rigid gas permeable contact lenses. Okay. When there is progressive changes, that the cornea is becoming constantly thinned, we do collagen cross linking. There is a procedure which is also called C3R or collagen cross linking. So what is collagen cross linking? In this, here is a picture telling you this beta. We apply a dye. So this is image to explain collagen cross linking. We apply a dye called riboflavin dye. Then you apply ultraviolet A rays, C3R procedure, collagen cross linking procedure. So what the ultraviolet A rays along with the dye they do, they bring about changes in the collagen structure of the cornea and they reduce the progression of the keratoconus, right? Then if the cornea has become very thin, we can give mechanical support to the cornea by putting what is known as intrastromal corneal ring segments. Intrastromal corneal ring segments are also known as intacs. Intacs. So here is the picture showing you intacs beta. So there was in the NEET PG exam, this image was given. So that becomes important for us also to know. So if you notice here carefully, you can see these semicircular, half semicircular, the semicircle means half, semicircular rings are there, which have been implanted within the stroma of the cornea to support the thin cornea. Okay, so these are known as intacs, my friends, and they are also treatment of keratoconus, right? And then in the cases where there is corneal scarring, we need to do corneal transplant, which is known as keratoplasty, right? So here you see the multiple corneal sutures you can see, which have been applied to suture the graft with the host tissue, right? So these are the treatment options. All of these are the treatment options for keratoconus. They can ask you about this: rigid gas permeable contact lenses, collagen cross linking, intrastromal corneal ring segment intacs, as well as keratoplasty. So please do remember, one liner question can be asked, image questions they can be asked better, right? Okay, then few more important things which we should revise in the cornea. So in the cornea, already we have discussed that the different, especially the iron, gets deposited in different conditions. So there are some other, you can say, substances which also get deposited in the cornea, and one of the very common one is the lipid deposition, which leads to arcus senilis. So what is arcus senilis? So what happens with the age, there is lipid deposition in the cornea, usually in the peripheral part, which starts in the superior and the inferior part of the cornea, and then that makes a ring. So lipid deposition with age is called arcus senilis. It does not affect the vision. Sometimes when it is in the young age, that is known as arcus juvenalis, which can be a sign of hyperlipidemia. So if a young person shows arcus, that is a lipid deposition, arcus juvenalis, that can be sign of hyperlipidemia, right? Then in certain conditions, the calcium gets deposited inside the cornea, and that leads to what is known as BSK, or band-shaped keratopathy. Band-shaped keratopathy, okay? That it's in the form of a band. Now, what can be the causes of the band-shaped keratopathy? Any condition in which the calcium is either high in the body, for example, any hypercalcemic condition, for example, multiple myopia, hyperparathyroidism, or certain eye conditions, chronic uveitis, especially in the cases of juvenile rheumatoid arthritis, that leads to band-shaped keratopathy, friends. Okay. Then phthisis bulbi, in which the eyeball shrinks in size, shrunken eyeball. Then silicone oil induced keratopathy. You know, in the retina surgery, we use silicone oil. So silicone oil can also cause band-shaped keratopathy. So please remember the causes of band-shaped keratopathy, and what happens in band-shaped keratopathy. There is deposition of the calcium. Then in corneal deposits, another important which we need to remember, my dear friends, is what is known as Kayser-Fleischer ring. So what is Kayser-Fleischer ring? Now this is an important question which has come many times now. So please see, in Kayser-Fleischer ring, the deposit is of copper. Okay, so I always tell for iron Fe Fleischer ring, this is Kayser-Fleischer ring. So K for Kayser-Fleischer ring, K for copper. So please remember by this. Okay, so Kayser-Fleischer ring is the copper deposition. Now this can be seen in Wilson's disease. which is a disease in which there is involvement of the liver as well as the neurological involvement, Wilson's disease. This can also occur in a condition called chalcosis. Okay, chalcosis. Chalcosis is when there is some copper foreign body which is there inside the eye, that also leads to copper deposition. So these are the two causes of KF ring, Wilson's disease and chalcosis. So this copper deposition, as you see, is in the peripheral part of the retina, cornea, right? And this starts in the superior part. This starts in the superior part. They can show you this image, so you can see, like, the different images are there depending upon the, like, how the color is there. So if you see something greenish, brownish, so that is your Wilson's, the KF ring. That is your KF ring. So you see, notice here this greenish brownish ring in the peripheral part, that is your KF ring which is seen, right? In the early stages, when it is very, very early stage, then gonioscopy is the best method. Gonioscopy is the best method to identify early KF ring. Okay. If it is well defined, you can see on the slit lamp, but if you want to pick it up in the early stages, then gonioscopy is the best method. Then another point to remember is that it is not pathognomic of Wilson's disease, and it is not present in all patients of Wilson's disease, right? It is not pathognomic because it can be seen in some other liver diseases also. So please remember, it is not pathognomic of Wilson's disease, and it is not present in all patients, because in Wilson's disease there are some patients who have more of neurological involvement, and then there are some patients who have more of hepatic involvement. This is more common with neurological involvement, right? More common with neurological involvement. So you can write it also here, more common in neurological involvement. So these points, they are important to be remembered because they can be asked in your exam. There can be a case scenario, beta, that there is a patient who is having like, the tremors, or like, signs specific of Wilson's disease, and on examination they give you the slit lamp picture. What is the diagnosis? That is KF ring. KF ring or in Wilson's disease. But please remember, it may be absent also. It is not present in all the patients, and it is not pathognomic of Wilson's disease. Okay, right? Right. So after finishing the important things which we need to revise for cornea, something about in the scleral conditions, from the quick revision point of view, in sclera we need to know few important points. So let's go with that. So first of all, they can ask you about which is the thinnest part of the sclera. The thinnest part of the sclera is posterior to the insertion of extraocular muscles. Okay, and in case you want to know the thickest part is around the optic nerve area, that is peripapillary area, right? And then whenever there is mention of scleritis, please remember rheumatoid arthritis. Okay, so very easy for scleritis, remember rheumatoid arthritis. So because the most common association of scleritis, if they ask you the association cause of scleritis, that is rheumatoid arthritis, right? Then especially in the patients who have long-standing rheumatoid arthritis. Okay, so again see here, long-standing rheumatoid arthritis, they show a necrotizing type of scleritis which is called scleromalacia perforans. Scleromalacia perforans. Now they can show you this image, friends. They can show you this image that this is a condition. The patient is a known case of rheumatoid arthritis, and you see this image. So you see, you are able to see that there is so much of scleral thinning that you can see the uveal tissue. Why this is appearing dark in color? Because the uveal tissue is shining through this. Uveal tissue is shining through because the sclera has become very thin. So the uveal tissue is shining through. So that is why it is called scleromalacia, thinning of the sclera. So this is again, please remember, is seen in the cases of long-standing cases of chronic cases of rheumatoid arthritis. Right? Then there is a condition, as we know, what is called as posterior scleritis, when there is inflammation of the posterior part of the sclera. So for posterior scleritis, remember two signs. One, on ultrasound B scan, when we do ultrasound B scan in these cases, we see a T sign. Okay, we need to just know this only, beta, for that. On ultrasound B scan, we see T sign, my friends. Okay, and posterior scleritis can also cause exudative retinal detachment. Right? So if there is in a question in which they are mentioning that there is an exudative retinal detachment and you see T sign on ultrasound B scan, so this can be indicative of that this is a case of posterior scleritis. This is a case of posterior scleritis. So scleritis, rheumatoid arthritis, scleromalacia, long-standing rheumatoid arthritis, and 2 points about posterior scleritis. And we can now move ahead in our revision, and now we are going to discuss important points which we need to revise from the lens and the diseases of the lens. Okay, right. So friends, in lens, most of the questions which they ask is because we know the cataract, the different morphological types of the cataract and different associations. So please do remember, most of these questions, they can be your one-liner question, that which type of the cataract is seen in which condition. Okay. Then they can ask you the questions based upon the intraocular lenses. They can ask you the questions based upon cataract surgery and complications of the cataract surgery. And that is what we are going to revise here now. Okay. So you are with me? Let's revise. Now in the congenital cataract, please remember the most common type of congenital cataract is blue dot cataract. Okay, most congenital common type of the cataract is blue dot cataract, but it is visually non-significant or insignificant, that it does not causes vision problem. Blue dot cataract does not causes vision problem. It is visually insignificant. So, the most common visually significant congenital cataract, is lamellar or zonular cataract. Lamellar or zonular cataract. And in the clinical signs of lamellar or zonular cataract, we see what is called as riders. So again remember, riders are feature of lamellar or zonular cataract. Your one-liners. Okay. Then moving ahead, in the acquired cataracts, beta, the points which we should know about the acquired cataracts. Most common type of acquired cataract will be age related, that is senile cataract. Now in nuclear sclerosis type of the senile cataract, if you remember, we have discussed, in nuclear sclerosis type of the senile cataract, we see what is called as second sight of old age. That patient is able to see the near things without glasses. That is called second sight of old age, which is due to index myopia, because the refractive index of the lens increases. So nuclear sclerosis is the type of cataract in which we see second sight of old age. Okay. Then in acquired cataract, we know there is a type of cataract which is called as posterior subcapsular cataract. Now this posterior subcapsular cataract is usually in the central area. So this cataract starts causing the vision problem very early. So posterior subcapsular cataract causes early vision disturbance. So if in the history they say that the patient is having the vision disturbance at a very early, the patient has early cataract but having vision disturbance, or patient is having glare with the bright light, then the type of cataract they are talking about is posterior subcapsular. If the patient is having difficulty of the vision in dim light, okay, in posterior subcapsular cataract, the glare will be in the bright lights, friends. If they are having the problem in dim light, so dim light, it means it's the cortical cataract cuneiform type. Cortical cataract cuneiform type. Then colored halos can also occur with cataract, and the colored halos are seen in early cortical cataract. Okay, colored halos are seen in early cortical cataract. And if you remember, let's revise here, FinCam test beta. FinCam test was the test to differentiate colored halos of glaucoma from cataract. Remember, if you want to differentiate the colored halos of glaucoma, angle closure glaucoma from cataract, then we do the FinCam test. So this again can be asked as one-liner question. This is a test to differentiate colored halos of glaucoma from cataract. Okay. Then they can ask you an image based question. They can show you this image and say that the patient is having glare of light or difficulty in bright light. Identify the type of the cataract. Okay. So see here, image beta, have a look at this image. Have a look at this image. Here you see your cornea is clear. Your lens is clear except for this opacity in the posterior subcapsular part. Right? This whole lens area is clear, but there is an opacity in the posterior subcapsular part. So please do remember, this is posterior subcapsular cataract. They can show you this image, my dear friends. So don't forget, this is posterior subcapsular cataract. This is also it also goes by the name of nodal cataract. Nodal cataract, because this area is known as the nodal point of the eye. Nodal cataract. Okay, so this image is important. You can see the rest of the lens will be clear and there will be opacity in the posterior part of the lens. Posterior part of the lens is the one which is away from the cornea towards the vitreous cavity. So this is your posterior subcapsular cataract or nodal cataract. Okay, this is the one which causes glare and early disturbance of the vision. Okay. Then, like we know, depending upon the maturity of the cataract, if the mature cataract becomes swollen or intumescent, it can cause glaucoma because it has become swollen. So this type of the glaucoma, friends, is known as phacomorphic glaucoma, which occurs due to intumescent mature cataract, right? So intumescent means swollen. The lens has become swollen. Phacomorphic glaucoma is caused by intumescent mature cataract. Then in the hypermature cataract, in the cases of Morgagnian hypermature cataract, we see phacolytic glaucoma because the cortex becomes milky. You remember Morgagnian cataract, remember milky cortex. milky cortex because it has become liquefied. So that causes phacolytic glaucoma. Morgangian milky cortex causes phacolytic glaucoma. And then the sclerotic type of the hypermature cataract. Sclerotic is shrunken. That causes dislocation of the lens. Okay, so these 3 points: intumescent, swollen, mature cataract, phacomorphic glaucoma; Morgangian hypermature cataract with milky cortex, my friends, phacolytic glaucoma; sclerotic hypermature cataract, this is shrunken in size, that causes complication of dislocation of the lens. Again, one-liner questions they can be asked here, beta, right? Then depending upon the morphology, this is more of a kind of a table, which type of cataract is seen where. So let's quickly revise this. In diabetic patients, especially the type 1 diabetics, friends, the snowflake cataract is seen in diabetics. Blunt trauma causes rosette cataract. Blunt trauma causes rosette cataract. The galactosemia causes oil drop cataract, and it is the only type of the cataract which can be reversible if you correct the galactosemia. Then in Wilson's disease, besides the KF ring, you can also see sunflower cataract. In Wilson's disease, you can also see sunflower cataract. Then in the myotonic dystrophy, the cataract has Christmas tree-like appearance. So remember this table, again important for one-liner questions, that what type of the cataract can be seen in these cases. Okay, more of kind of little memorizing there, right? So then they can show you this image also, and they can show you, they can ask you a case scenario, right? So do you remember this image, my friends? So they can give you a case scenario that a patient was, or a person was hit by a cricket ball. After a few weeks or months, he developed decrease in the vision, and this is the image. Okay, so what can be the case? Injury with cricket ball or injury with a fist, and this is seen. Right? So what do you see, my friends? Here you are seeing a type of cataract which is in the form of, we just discussed, rosette cataract. So this is the image of your rosette cataract. So they can show you the image, they can give you the case scenario. So rosette cataract is associated with blunt trauma, something like injury with the ball, injury with the punch, injury with the fist, something like that. So if this image is there, that is your rosette cataract, friends, right? I think rosette is double S there. Then another thing which we should remember in the cataract and different types of the cataract is what is known as complicated cataract. Okay, so do you remember what is complicated cataract? So complicated cataract is when the cataract is caused by some other ocular problem, when it is caused by some other ocular problem. Now complicated cataract has certain special features. So first of all, what is the type of the complicated cataract? So once again, I think now you can easily identify what is the morphology of the cataract here, friends. Again, it is the posterior subcapsular type of the cataract, isn't it? Right? Rest of the lens is normal and posterior subcapsular cataract is seen. Now this type of the cataract, if you see, it has got a crumby appearance, like crumbled. It has a crumbled appearance. This is called breadcrumb appearance, right? And if you see, it has got a very typical luster. It's shiny. So when you do the slit lamp examination, it has what is known as polychromatic luster. It has what is known as polychromatic luster. So if they tell you that there is a cataract which shows breadcrumb appearance or a polychromatic luster, then you know they are talking about then you know they are talking about complicated cataract. And which type of the cataract is this? Posterior subcapsular. Posterior subcapsular cataract. Right? Okay. Okay, so then something more about certain lens conditions. Again, your one-liner questions, they can be asked. The glass blower cataract. The glass blower cataract means when there is a cataract due to high heat, it causes exfoliation of the lens capsule. So it is called true exfoliation cataract. Then we know certain drugs, they can cause cataracts, and in the drugs, please don't forget steroids. And when the steroids, they cause the cataract, again they cause posterior subcapsular cataract. So please remember, we have revised, so you have to a bit of kind of memorize these, which type of the cataract is seen in which condition. Right? Then the lens can be dislocated or subluxated from its normal position. So that is known as ectopia lentis. Okay, so when there is the subluxation of the lens, that is known as ectopia lentis, and in conditions with ectopia lentis, we should remember two conditions. One is known as Marfan syndrome. In Marfan syndrome, the lens gets dislocated superotemporally, and then you should remember homocystinuria, in which it gets dislocated infranasally. So these are the two conditions in which there is dislocation of the lens: Marfan syndrome and homocystinuria. Right? So this was the list of all the important conditions. Now coming on to the management of the cataract type, and this is again an important topic, friends, because they will ask you about what type of the surgery or different type of the lenses. So let's revise all the important points here. So first of all, in the cataract surgery, as I told you, in the modern day cataract surgery, besides the phacoemulsification, we are using the laser also. So which laser is used in the modern cataract surgery? Please remember, it is femtosecond laser. The laser which is used in the cataract surgery is femtosecond laser. So we know after removing the cataract, we put an intraocular lens. So where you should put the intraocular lens? What is the ideal site for intraocular lens implantation? That is in the capsular bag. So all these, they can be bit of one-liner questions. Intraocular implantation should be done in the capsular bag. Then intraocular lenses, they are of two types. One are known as flexible. In the flexible, acrylic is the commonly used and the best material. Then we have the rigid lenses also. For the rigid lenses, we use PMMA material, which is polymethyl methacrylate material. Okay. Then in the IOL power calculation, because when you want to calculate the lens power, the formula which is most commonly used is SRK2 formula. IOL power formula, SRK2 formula. But in the cases when the refractive surgery has been done, you know, we discussed LASIK, SMILE, etc. So in those cases, the corneal curvature is changed. So you cannot use SRK2 formula. So in those cases, in post-refractory surgery cases, the formula which should be used is Haig's formula or Holiday 2 formula, friends. So again, this can be asked as a question, right? So normally for standard cases, SRK2 formula, but the cases which are post-LASIK, post-refractive surgery, Haig's formula or Holiday 2 formula, right? Then something about the cataract surgery and intraocular implantation in the children. Now this was the question in your last session exam, friends. So please see here. Now in children, when you do the cataract surgery, we know the size of the eyeball in a child is different from the adult, and the eyeball is growing in size. Okay, so if you remember from the class notes, at birth, the size of eyeball is considered to be about 16 millimeter or so, 15 to 16 millimeter, and the adult size is about 24 millimeter. And the child is also hypermetropic. The eye is hypermetropic, about +2 to +3 diopter. This is the normal thing in when a child is born. But when the child is growing, the eyeball will also grow. So when the eyeball grows in size, the axial length of the eyeball increases. There is a shift of the refractive status of the eye from hypermetropia to myopia. So this is known as myopic shift. Okay, so friends, what happens at birth? The eye is hypermetropic because eyeball is small in size. But then with age, eyeball will grow. Eyeball grows in size, and there is myopic shift in the refractive state, right? So if you are operating, for example, a 1-year-old child, so the eyeball is still to grow. So whatever lens power you calculate in those cases will not be accurate once the child has become 5 years of age or once the child has become adult, because you calculated according to the axial length or the size of the eyeball when the child was of 1 year. So in a child, when you are talking about calculation of intraocular lens power, right? Please listen to me carefully. In the children, when we are talking about calculation of intraocular lens power, we have to consider that now the child is in hypermetropic kind of state. The eyeball is going to grow, and that will lead to what is known as myopic shift. So this power will change. So taking into account of the myopic shift, the lens power is undercorrected in the children. So whatever power I get from the formula, I reduce it, I undercorrect it, because I know the child is going to have myopic shift when the eyeball grows, right? So if the child age is less than 2 years, I will use 80% of the IOL power, which I got from the formula, right? Between 2 to 8 years of the age, I will use 90% of the power, which I got from the formula. And once the child is more than 8 years of the age, by that time the eyeball growth is nearly stabilized. I can use the 100% power, like whatever I get with the formula, just like an adult. Okay, so this was a question they asked about the myopic shift in the question. So in the cases of children, once again I'm stressing upon this, in the cases of children, when you are calculating the intraocular lens power, keep into account myopic shift, right? Okay. Then moving ahead, beta, in the cataract surgery, post cataract surgery, the patient can have certain kind of complications also. And here what we need to remember is the most common late complication of cataract surgery, because there can be certain early complications, late complications, but the most common late complication of the cataract surgery is what is known as after cataract or posterior capsular opacification. Posterior capsular opacification. So as you can see here in this image, this is to make you understand the capsule on which the lens is resting becomes opacified. So you can see this opacified capsule. So this again leads to decrease in the vision because it is not transparent. The vision decreases. Now this PCO can be in the form of what is known as Elschnig pearls, like you are seeing here, Elschnig pearls, or the second type is called as Sommering ring. So this is the pattern of the opacified capsule which can be seen. Elschnig pearls and Sommering ring. And because this happens after the cataract surgery, once again the vision has gone down. So that is why you call it as after cataract. What do I do for this? There is a treatment for this. I make an opening in the lens capsule with the help of the laser. So what I will do, I will create an opening here with the help of the laser. This procedure is known as capsulotomy. This procedure is known as capsulotomy, and the laser which I use is known as ND-YAG laser. Right? So they can ask you this question, what is the treatment of the after cataract? The treatment of the after cataract is you do capsulotomy using ND-YAG laser. So this is the most common late complication of cataract surgery. Then after this, let's revise what is the most dangerous complication of the cataract surgery. Right? So after cataract surgery, most dangerous or sight threatening, you can say, complication is what is known as endophthalmitis. Endophthalmitis. Okay. So please remember, friends, most dangerous complication is endophthalmitis. Now endophthalmitis can occur as an acute endophthalmitis, that is within 7 days. Acute means which is occurring within 7 days of surgery. Within 7 days of cataract surgery, and the cause is staph epidermidis. And sometimes it can occur months after the surgery, which is called as late endophthalmitis. Late endophthalmitis is mostly caused by Propionibacterium acne or due to fungi. So please remember, most dangerous complication is endophthalmitis, which can cause loss of vision. Now, in the treatment of the endophthalmitis, two choices are there. You give intravitreal antibiotics, that is, you inject the antibiotics into the vitreous cavity, or you can do pars plana vitrectomy surgery to clear the infection or the exudates in the vitreous cavity. Okay? So, these are the points which you should remember about endophthalmitis, the causes and the treatment. Right. Okay. Right. So this was mainly about the lenses. As I told you in the beginning, try to remember different morphologies of the different type of the cataracts, etiologies, then image of the rosette cataract, posterior subcapsular cataract, complicated cataract, points regarding the cataract surgery, intraocular power calculation, and the complications. Okay, friends? Okay. So with this, we can move on to the next topic for our revision, and that is glaucoma. Let's now revise the important points which are high yield points for our exam from glaucoma. Ready? Right. Okay. So in glaucoma, as regard the physiology part, you can say what again can be asked as the one-liner question. They can ask you that how the aqueous humor is produced. So we remember very well, it is produced by the ciliary processes of the ciliary body, or what is also called as pars plicaita. Remember, pars plicaita. And what the aqueous humor does, it provides nutrition to two avascular structures, which are your cornea and lens. Remember? Now, the aqueous humor is being continuously produced and it has to be drained out also continuously. So, for the drainage of the aqueous humor, we remember there are two pathways. The major outflow pathway is your trabecular meshwork pathway. The major outflow pathway is trabecular meshwork pathway. And the minor outflow pathway is uveoscleral pathway. Uveoscleral pathway. Okay. And what is the normal range of the intraocular pressure? That's the pressure within the eyeball, that is between 10 to 21 millimeter of mercury. 10 to 21 millimeter of mercury. And as we have learned in our classes, that if there is any obstruction to the outflow of the humor, aqueous humor, whether it is due to some blockade in the area of trabecular meshwork or due to closure of the angle that the aqueous cannot outflow, the pressure will rise. Right? So all of you know why the glaucoma will occur. So whenever there is some obstruction to the outflow of the aqueous humor due to different reasons, that will lead to increase in the pressure and that will lead to the damage to the optic nerve and that will cause the vision problem. Remember, right? Now let's see some further important points in the related to glaucoma and intraocular pressure. So first of all, you have to remember how do we measure the intraocular pressure? How do we measure the intraocular pressure? So the investigation which is done to measure the intraocular pressure is known as tonometry. Tonometry. So what is tonometry? Tonometry, friends, is measurement of intraocular pressure. Okay, in the short we call it as IOP. Now in this image, again, which can be asked as an image based question, in this image, the instrument which you are seeing, my dear friends, please remember it is your Goldmann applanation tonometer. The image which you are seeing here is Goldmann applanation tonometer. So this can be asked as an image based question. So if you see carefully here, you can notice that this part is actually the Goldmann applanation tonometer, which is attached to the slit lamp that touches the cornea, applanates the cornea, and that helps us in getting the measurement of intraocular pressure. So if this image is there, a small instrument touching the cornea, we see it under cobalt blue filter light. This is Goldmann applanation tonometer. And the Goldmann applanation tonometer, my dear friends, is the best method. It is the best method, or what we call as gold standard method. Gold standard method for measuring intraocular pressure. Right? Okay? Right. So after the tonometry, now coming on to the signs or the changes which we see in optic nerve, because as I told you, when there is high pressure, that will damage the optic nerve. So there are specific signs. There are specific signs which we see in the optic nerve due to glaucoma. So if you notice here, let's revise what we have already learnt in our classes. So if you see here, this is the normal optic nerve. Okay. So this is a small cup. All the vessels, they are normally placed here. The position of the vessels, everything is normal. Right. This is your neuroretinal rim. This is the neuroretinal rim. This is the cup, right? So in glaucoma, what happens? There is increased cupping. There is increased cupping. So the normal cupping is 0.3 to 0.5. The normal cupping is 0.3 to 0.5. So when there is increased cupping, that is one sign of glaucomatous damage, right? Then the presence of hemorrhage on the optic nerve, what is called as splinter hemorrhage. You see this small hemorrhage, this is called splinter hemorrhage. The presence of hemorrhage on the optic nerve. Here you see further, you can see the cupping is increasing. The cupping is increasing. Then when the cupping is increasing, the vessels, they are being pushed on the nasal side, what is called as nasalization of the vessels. The vessels are being pushed on the nasal side. Then another feature is the vessels, they show bayoneting sign. Bayoneting of the vessels, they are going deep and then coming up. Bayoneting of the vessels. And then there is what is called as laminar dot sign. So as you see, the cup has increased so much and you see this laminar dot sign. So all these are the signs of the optic disc damage due to glaucoma. So it is glaucomatous optic nerve changes. Glaucomatous optic nerve changes. Okay, so they can be asked in the exam. Please remember all the glaucomatous optic nerve changes. So whenever there are nerve changes, there are going to be changes in the visual field. So what are the field changes which you will see in the cases of glaucoma? So what are the visual field changes which you will see in the cases of glaucoma, friends? So visual field defects in glaucoma. So in the visual field defects in glaucoma, again keep looking at this figure, friends. So first of all, there is localized constriction of the visual field and there is bearing of the blind spot. Bearing of the blind spot. Okay. Then you will notice that there are small paracentral scotomas. Okay. So paracentral scotomas as you are seeing here. Then these paracentral scotomas, they join the blind spot and they make a sedal scotoma. They have made a sedal scotoma, a comma-like scotoma, comma-shaped scotoma, sedal scotoma. The further damage leads to an arcuate, an arc-like scotoma, right? So this arcuate scotoma is called Jerem's arcuate scotoma. Jerem's arcuate scotoma. Now when there are, superior arcuate as well as inferior arcuate, that is called, you see, superior arcuate and inferior arcuate, then this is called double arcuate scotoma or annular scotoma. Double arcuate and annular scotoma. Now here you notice these scotoma, they are not corresponding. There is a step here. They are not corresponding. This step is called as Rene's nasal step. This is called as Rene's nasal step, which is again a feature of glaucoma changes. Okay. And when the field defect further increases, the whole of the visual field is lost except for small central and temporal island is only left. The rest of the field is all lost. only temporal and central island is left. So, please remember the name of all these visual defects. They can again be asked in your exam as one-liner question. Bearing of the blind spot, paracentral scotoma, sedal scotoma, Jerem's arcuate scotoma, double arcuate scotoma, Rene's nasal step, and in the last, only temporal and central field is left, rest everything is lost. So these are the features of glaucomatous visual field defect, friends. Okay, right? Then what else is important to revise in glaucoma is a very important condition from exam point of view, which is known as congenital glaucoma, friends. Congenital glaucoma is also called buophthalmos. Buophthalmos means big sized eyeballs like a bull. Big sized eyeballs like a bull. Okay. So, what will be now? This can be again asked as an image question. This can be asked as a case question. So, what can be the case scenario? What can be the case scenario? That the parents, they bring a maybe 1-year-old child with the complaints of watering, photophobia, and blepharospasm. Blepharospasm means squeezing of the eyeballs. Okay, so watering can also be called as lacrimation. So this will be the case history, that the parents, they bring a child with lacrimation, photophobia, and blepharospasm. On examination, this image is seen. What is your diagnosis? So your diagnosis will be congenital glaucoma or buophthalmos. Okay, so you can remember these features as BPL, BPL, right? Blepharospasm, photophobia, and lacrimation. And what do you see? What signs you see in the image? So please notice here with me. You see big sized eyeballs. The eyeball size is increased, as you can notice in both eyes. This eye more than this. Similarly, you see a large cornea. See the size of the cornea, that is increased. This is called megalocornea. In this case, both corneas, they are hazy. That is, there is corneal opacity, right? There can also be bluish discoloration of the sclera. And because of the stretching of the eyeball, we see stria or folds in the descent membrane, which are known as Hab stria, which are feature of buophthalmos. So if you remember, I told you about Vogue stria, the Vogue stria which were seen in keratoconus. So similarly, in buophthalmos, we see Hab stria, Hab stria. Okay, so how will you identify what are the features? As I am telling you, I can write it down here. So there will be large sized eyeball, okay. There will be what we call as large cornea. The large cornea is known as megalocornea, right? There can be bluish sclera. The cornea can be opaque also. It can be clear or opaque. So either thing can be there. And we see Hab stria. Okay. So would you remember this picture and the clinical case scenario, friends? Right. So this is important, very, very important. Then in the management of congenital glaucoma, the management is always surgery for congenital glaucoma, the definitive management, and two types of surgeries are available. One is called goniotomy and the other is called trabeculotomy. Okay. So if the cornea is clear, then we can perform goniotomy. If the cornea is clear, we can perform goniotomy. But if the cornea is hazy or opaque, then we have to perform trabeculotomy because you cannot do goniotomy. Okay, is that clear? Right? So, remember these points about congenital glaucoma, friends. Then regarding the treatment of glaucoma, okay, different medications are available. So this is again a very important exam topic, the different medications, the mechanism of action of those medications and side effects of those medications. So maybe you have already done something in the pharmacology also, but we did it in our classes also. So the points which are very important from ophtha point of view. So you have to remember what is the first line anti-glaucoma drug or a drug of choice. So if you diagnose a patient with having glaucoma and you want to start him on the medication, so what should be the drug of choice? So please always mark as prostaglandin analogs. Please mark as prostaglandin analogs. So different prostaglandin analogs are available: latanoprost, travoprost, bimatoprost, tefloprost. So whenever there is prost at the end, that will tell you that this is a prostaglandin analog. So they are the first choice. Okay. Then they can ask you the mechanism of action of prostaglandin analogs, friends. They increase uveoscleral outflow. They increase uveoscleral outflow. Okay. And the most common side effect of prostaglandin analog is they cause trichomegaly, that is increase in the number and size of eyelashes, and they also cause change in the iris color. They lead to dark colored iris. Okay. And as you know, prostaglandins are the inflammatory mediator. So they are contraindicated. They are contraindicated in uveitis and cystoid macular edema, that is CME. Okay, so they are contraindicated in uveitis and cystoid macular edema, your prostaglandins, but otherwise they are the drug of choice or first line treatment. Okay, then in the glaucoma drugs, we have to remember about beta blockers. So this was the question also in the last exam. So beta blockers are the drugs which will be contraindicated if the patient is having asthma, if the patient is having COPD or heart block. Okay, because they can worsen the asthma. So do not give beta blockers to a patient of asthma, COPD or heart block. Then in children, the drug which is contraindicated is brimonidine, because it causes CNS depression and it also causes sleep apnea. So brimonidine is contraindicated in children. Right? Now for the acute angle closure glaucoma, whenever there is attack of acute angle closure glaucoma, the topical drop which you will give is pilocarpine. And the drug which is contraindicated in acute angle closure glaucoma is atropine, because atropine dilates the pupil. You do not want to give atropine because that will not let the pressure be okay. Okay, right? And then there is one drug which increases the risk of retinal detachment. Which anti-glaucoma drug increases the risk of retinal detachment? That is your pilocarpine. And besides prostaglandin, pilocarpine is also another drug which is contraindicated in uveitis with glaucoma. So drug contraindicated in uveitis. The two drugs, because the patients having uveitis can also have high pressure, But in those cases, you will never give pilocarpine or you will never give prostaglandin analogs. You will use different drugs. So these were the points in the anti-glaucoma drugs which you should absolutely know for your exam. So they are the important topic there, beta. Right? Then we also do certain laser procedures for the glaucoma conditions. So you know, in angle closure glaucoma, there is pupil block. So in the patients who have angle closure, to prevent the pupil block in the future, a laser is done which is called as ND-YAG laser. ND-YAG laser. Okay. So laser which is done for angle closure glaucoma is ND-YAG laser iridotomy. You make an opening in the iris. ND-YAG laser iridotomy. Then laser can also be done for open angle glaucoma. The procedure is called as laser trabeculoplasty. Laser trabeculoplasty. Then the patients who do not respond to laser or to medication, they are taken up for the surgery, and the surgical procedure for glaucoma is called as trabeculectomy. Trabeculectomy. Okay. And in certain patients or in certain conditions, we know the trabeculectomy also does not work or has failed. We have drainage implants. These drainage implants, they are also called Seton surgery or glaucoma valve surgery, right? So please remember this word. Seton surgery is also known as glaucoma valve surgery or drainage implant. So that is also a procedure which is done for the glaucoma patients, right? So here this is an image. They can show you this image also, the image based question, another image based question from glaucoma. So what do you see here? What do you see here? So, okay, so if you see here carefully, cornea is clear, the eye is not red, lens is clear. So what are you seeing here? You are able to see that there is an opening. There is an opening in the peripheral part of the lens. This is what is, as I was just telling you, this is the laser iridotomy which has been done. Laser iridotomy which has been done, which is done for cases of angle closure glaucoma, which is done for the cases of angle closure glaucoma. All right. Okay. Right. So that was about your different glaucoma conditions. Please don't forget about to learn about or to revise about the medications. And the procedures. Okay, right? So friends, let's move on to another topic, retina, which is important for images and certain different case scenarios. So we'll be revising the important case scenarios, important images, conditions in retina. So are you ready to move on to retina? Okay. So in retina, I'm just going to help you recall the basic anatomy so that you are quick to pick up the things here. So if you remember, especially in the central part of the retina, when we are examining, what we are seeing on the fundus examination, so you see the optic nerve, right? The optic nerve, which I already told you, in the center you notice the optic cup and then the neuroretinal rim. Then from the optic nerve, there are coming out the branches of the central retinal artery and central retinal vein. So you see the branches of these vessels, central artery, retinal artery and central retinal vein, which are going, okay, temporal branches, nasal branches, superior, inferior branches. Then the central part of the retina, this area is, as you know, as you remember, is known as the macular area. Within the macular area, we have the fovea. fovea. And within the fovea, the small area is called as, if you remember, foveola. Okay. And as we have already been discussing in the classes, it's the central area of the retina, that is the fovea or foveola, which is responsible for the fine vision, because highest number of the cones are there. Okay. So remember this, when we see the fundus image, this is how the normal fundus looks like. Normal optic disc, normal blood vessels, macular area. Now if there are any changes, then it means there is some disease going on, and what is the different fundus picture in different diseases, we are going to revise now. Okay. Okay. So before coming to the diseases, let's recall that what are the two investigations which help us diagnosing the retinal diseases. Now these can again be asked as an image based question. They can show you this image and they can ask you to identify the investigation. Identify the investigation. So you can see that this is a fundus image, but this is not the photograph of the fundus, because you see this is a black and white image, and you see the blood vessels, they are having this whitish appearance. So when you see something like this, please identify that this is a picture of fluorescein angiography. Fluorescein angiography or fundus fluorescein angiography, FFA. Because you have injected the fluorescent dye to study the retinal vascular diseases. So this is the investigation for the vascular diseases. This is the investigation for the vascular diseases, my friends. Okay. So they can show you the image. As I told you, when you see these white vessels and optic disc, retinal vessels, it means it is a fluorescent angiography test, fundus fluorescent angiography, which is done to study the vascular diseases. Okay. The second important investigation is this. So they can show you this image. This is a colored image. They can also show you a black and white image. So this is OCT. This is OCT. OCT means optical coherence tomography. This is optical coherence tomography. So this helps me to study diseases of macula. So this is investigation of choice for diseases of macula. Investigation of choice. Macula, the central area which I told you. Okay. So if you see here, this is actually showing all the different layers of the retina. So in the macular area. So you can study all of these. If there is any problem in this, we can pick up on the optical coherence tomography. So these two investigations, images, fundus fluorescent angiography, optical coherence tomography. Okay, friends? Right. Now, coming to the different retinal diseases, and let's revise the important points. So first of all, let's see about retinal detachment. Okay. So they can ask you a one-liner. What is retinal detachment? The retinal detachment is when the neurosensory part of the retina, separates from RPE, that is retinal pigment epithelium. Okay. What is RPE? Retinal pigment epithelial layer. When it separates from retinal pigment epithelium and there is a collection of fluid, subretinal fluid, that is the retinal detachment. Okay. So retinal detachment, as I was discussing in myopia also, it usually occurs when there is a retinal break. Okay. Now in the retina, if they ask you that what is the most common retinal degeneration, the most common retinal degeneration is lattice degeneration. And in lattice degeneration, when there is a retinal break, then the type of detachment which is caused is called as rhegmatogenous RD. Remember, we have learnt in our classes, there are three types of the retinal detachment: rhegmatogenous, tractional and exudative. Now, when the detachment is due to a retinal break, then it is called as rhegmatogenous retinal detachment. Now, retinal breaks, they can be of different types. They can be holes, they can be small tears, but which is the most dangerous retinal break? The most dangerous retinal break is the horseshoe type of the tear. Horseshoe type of the tear. Because that then there is a high risk of development of retinal detachment. And which is the most dangerous location of this kind of break? That is superotemporal part of the retina. Superotemporal part of the retina. Okay, so let me show you this image here. So this, what I was talking about, this is showing you a horseshoe tear, you know, like a horseshoe. This is a horseshoe retinal tear. And this type of the tear can lead to retinal detachment. You see this whole area, the retina is ballooned up. It is detached and there is a collection of subretinal fluid under that. Okay. So they can show you this image also. Beta, please remember, this can be your image question. You can see a tear in the retina and detachment of the retina. Okay, right? Now, something more about the rhegmatogenous retinal detachment, because this can come as a case scenario. Very, very important. It has come in the last exam also. So, what can be the case scenario of rhegmatogenous retinal detachment? They will tell you that the patient is having signs of flashes of light, which are also known as photopsia, or floaters, and then a curtain like shadow. So whenever there is this word curtain like shadow, it means they are talking about retinal detachment, especially rhegmatogenous, because this is how it progresses. It causes a curtain like shadow in the field of vision. Okay, so please remember, if there is a case in which a patient presents with floaters of the light, flashes of the light, and then a curtain like shadow coming in front of the eye, that is a case of rhegmatogenous retinal detachment. The other features which you see in rhegmatogenous retinal detachment is what is known as Schaeffer sign or tobacco dusting, which is a pigment in the vitreous cavity. So this is also a feature of the rhegmatogenous RD. So Schaeffer sign or tobacco dusting is a pigment in the vitreous cavity, again a feature of rhegmatogenous retinal detachment. So again I am highlighting, please remember, curtain like shadow, symptoms of flashes or floaters. Please remember rhegmatogenous retinal detachment, friends. Then two more important points to remember. First is, what is the most common cause of tractional type of retinal detachment? So there can be different causes of the tractional retinal detachment. What is the most common cause? The most common cause is proliferative diabetic retinopathy. So this can be your one-liner question. What is the most common cause of tractional retinal detachment? That is proliferative diabetic retinopathy. Then another one-liner question can be asked, the shifting fluid sign. The shifting fluid sign is seen in. Now this, my friends, is the feature of exudative RD. This is a feature of exudative RD. Okay. So rhegmatogenous RD questions, important point about tractional retinal detachment and shifting signs seen in exudative retinal detachment. And please do remember this image also of horseshoe tear and retinal detachment. Okay, friends? Fine. So moving ahead to the topic of diabetic retinopathy and what all important is to be revised in diabetic retinopathy. So we know the diabetic retinopathy are the changes which we see in the retina in a diabetic patient. Now the stages, they can be early stages, what is known as non-proliferative diabetic retinopathy, and then the late stages, what is known as proliferative diabetic retinopathy. Now the signs which you see in the fundus in the non-proliferative diabetic retinopathy, all very, very important. So let's do them one by one. So first of all, microaneurysms are the earliest and the hallmark sign of diabetic retinopathy. Okay, microaneurysms are the earliest and hallmark sign of diabetic retinopathy. Besides that, we can see the lipid deposits, what are known as hard exudates. We see soft exudates, which are also known as cotton wool spots. These cotton wool spots are actually ischemic areas. They are localized ischemic areas. Then we see dot and blot hemorrhages. Then there is absence of new vessels. Now this is what beta? New vessels, they differentiate between non-proliferative and proliferative. Once new vessels are there, then the stage becomes proliferative. Okay, so when they tell you the new vessels are present, then the diagnosis is proliferative diabetic retinopathy. In non-proliferative, the new vessels, they have to be absent. They have to be absent. Okay, so have a look at the fundus picture of this non-proliferative diabetic retinopathy. So you see the small red dots. The small red dots will be your microaneurysms. Okay, then these yellowish deposits, they are the lipid deposits. These are your hard exudates. These small dots will be your microaneurysms. Okay, then this kind of, like, white fluffy, this cotton wool like. So these are your cotton wool spots, like cotton wool spots. These are the ischemic areas, right? And here you see the hemorrhages, the bigger hemorrhages, dot and blot hemorrhages on the surface of the retina. Dot blot hemorrhages. But as you notice, there are no new vessels. There are no new vessels. So please remember the fundus signs and the image of non-proliferative diabetic retinopathy. Non-proliferative diabetic retinopathy. So what will you see in proliferative? Let me show you what I was talking about. So here, if you notice, look at this image carefully. Very, very important image, can be asked in your exam. So here what you see these vessels on the optic nerve. These vessels are the new vessels because they are not the normal vessels. They are the new vessels or neovascularization which has occurred on the optic disc. Similarly, if you see, these are the new vessels on the surface of the retina elsewhere. So once you see these big new vessels on the surface of retina, then the stage is proliferative diabetic retinopathy. Okay, so this can be asked as an image question. This can be asked as a theory question, that neovascularization is the hallmark. Okay, so neovascularization is the hallmark of PDR, proliferative diabetic retinopathy. The new vessels, when you see on the disc, they are called NVD, new vessels on the disc, and when they are seen elsewhere on the retina, they are called NVE, new vessels elsewhere, right? So if you see the fundus picture, in which these new vessels are there beta, then the stage is proliferative diabetic retinopathy. There should be no confusion in that. It is a stage of proliferative diabetic retinopathy. Is that clear? Then another thing which happens in the cases of diabetic patients is the what we call as diabetic macular edema. Diabetic macular edema. In this, what happens? There is thickening of the retina. and the hard exudate deposition in macular area. Macular area, you see, here is the central area, and you see all these yellowish deposits in the macular area. These are the hard exudates once again. And if you do the OCT, you will notice that there is thickening of the retina. The thickening of the retina is due to the fluid collection in the retina. Okay, so this is the diabetic macular edema. Now, diabetic macular edema can occur in any stage of diabetic retinopathy. It can occur with non-proliferative stage as well as it can occur with proliferative stage. And it is the most common cause of vision loss, okay, because it is involving the macular area. So that is the most common cause of vision loss in the cases of diabetic retinopathy. Fine, right? Then in diabetic retinopathy, besides the diabetic macular edema, coming back to the proliferative diabetic retinopathy, so when it worsens, what are the complications which can occur? So let's revise that also. So remember, we have studied the complication. It can cause vitreous hemorrhage, right? It can cause tractional retinal detachment, TRD, tractional retinal detachment, and it can also cause rubeosis iridis. Rubeosis iridis. Okay, so remember the complications of proliferative diabetic retinopathy: vitreous hemorrhage, tractional retinal detachment, and rubeosis iridis. Now, coming to the treatment of the diabetic retinopathy, the treatment will depend upon what is the condition you are treating. Okay, when there is proliferative stage, proliferative diabetic retinopathy, then we need to do a laser, and this laser is called pan-retinal photocoagulation laser, that is PRP laser. Okay, pan-retinal photocoagulation laser or PRP laser. If it is diabetic maculopathy, then we do the laser only in that area. So that laser is called as focal laser or grid laser. Right? Then we also have what we call as intravitreal anti-VEGF injections, the injections which are given in the vitreous cavity. So if you remember, in our classes we have learned that is VEGF. VEGF is vascular endothelial growth factor. Vascular endothelial growth factor, which is the angiogenic chemical which is produced in the eye, angiogenic mediator, which is responsible for the diabetic retinopathy changes. So we give injections, anti-VEGF injections, which helps us in controlling the diabetic edema as well as the proliferative changes. Okay, and we can also do the surgery, which is known as pars plana vitrectomy. The surgery is done in the cases when there is vitreous hemorrhage, bleeding in the vitreous cavity, or when there is tractional retinal detachment. Okay, so the treatment will depend upon, as I told you, proliferative disease, PRP laser; for diabetic edema, focal laser or grid laser. We also give anti-VEGF injections, and when there is vitreous hemorrhage or tractional retinal detachment, then we go for pars plana vitrectomy surgery. Then another important thing to remember about diabetic retinopathy is the examination schedule. Again, they can ask you a question: when should you screen or when you should take a patient for fundus examination for diabetic retinopathy? Now, this differs between type 1 and type 2. For type 1 diabetics, as I have mentioned here, the examination is to be started 5 years after the onset or after puberty. because that is the time when changes occur. But very importantly, for type 2 diabetic, the fundus examination should be done as soon as is diagnosed with diabetes. So at the time of diabetic diagnosis only, you should do the fundus examination. Okay, even if the vision is normal, the examination should be done, right? So this again can be asked in your exam, friends. Then few more retinal vascular conditions which can come as the case scenario. They can come as image based question, very important. Let's revise them. So first is your beta central retinal vein occlusion, or CRVO. So how the patient will present? So normally it can be a hypertensive patient, or a diabetic patient who will have sudden painless loss of vision. So this will be the case scenario. Okay. So this will be the case scenario that a hypertensive or diabetic patient presents with sudden painless loss of vision, and this will be the image. So how will you identify a case of central retinal vein occlusion? So in central retinal vein occlusion, when you see that whole of the retina is having all these scattered retinal hemorrhages, you see multiple scattered retinal hemorrhages, in all the quadrants. So that will let you know that this is a case of central retinal vein occlusion. Right? So this kind of the appearance is also given a special name. It is called tomato splash appearance or blood in thunder appearance, because whole of the retina, as if blood is spluttered on the surface of the retina. So please remember the clinical features, the clinical symptoms: sudden painless loss of vision with retinal hemorrhages all over. That is the diagnosis of central retinal vein occlusion. And in central retinal vein occlusion, please remember a complication which is neovascular glaucoma. The neovascular glaucoma which occurs in CRVO is called as 90-day or 100-day glaucoma. So it is the type of neovascular glaucoma which we see in the cases of CRVO. Neovascular glaucoma. Right? Now, a similar kind of clinical symptoms can be seen in another condition. Again, there can be history of sudden painless loss of vision. In a coronary artery disease patient or hypertensive patient. Okay, so this will be the case. But fundus image will be totally different. So what is the fundus image here? You see, whole of the retina is pale. Due to ischemia. And in the center there is a cherry red spot. So if this is the case, then it is the case of central retinal artery occlusion. Okay, so two fundus pictures are very, very different. In central retinal vein, you see lot of hemorrhages on the retina. In central retinal artery, the retina is appearing whitish or pale due to ischemia, and there is a cherry red spot. And in some cases, you can also see cattle truck appearance of the blood vessels due to the blocked blood flow. Okay, so this is also seen in the cases of central retinal artery occlusion. So they are often asked as image based questions, so please do remember them. Okay. Okay, then going ahead to another retinal condition, which is age related macular degeneration. Age related macular degeneration. Now age related macular degeneration, friends, we have to remember two things. There are two main types. One is called as dry AMD and another is called as wet ARMD or exudative ARMD. Now in dry ARMD, there are yellow deposits in the central retina, okay, but no other changes, no hemorrhages, nothing. Only yellow deposits in the central retina, what are called as drusens. Okay, so yellowish deposits which are called as drusens. Okay, so this is what we see in dry ARMD. Whereas in wet ARMD or in exudative ARMD, there is a formation of choroidal neovascular membrane. Choroidal neovascular membrane, due to which there will be hemorrhage or fluid in the central retina. Hemorrhage or fluid in the central retina. Okay, and what is the treatment of the neovascular ARMD? For this, the treatment we give anti-VEGF injections. Anti-VEGF injections. Okay, the treatment of wet ARMD is anti-VEGF injections. Right? Then coming to another condition which can be asked as an case scenario or as an image based case. Okay, so case scenario or as an image question, that is your retinitis pigmentosa, my friends. Retinitis pigmentosa. So what we do in retinitis pigmentosa, so we know that it is a disease of the rod photoreceptors. Okay, so remember, it is a disease of the rod photoreceptors, and rod photoreceptors are responsible for the vision in the dim light. So when there is degeneration of the rod photoreceptors, the patient will present with again night blindness. Night blindness, and the rods are mostly present in the peripheral part of the retina. So there will be ring scotoma in these patients. So these patients will have difficulty in driving because of the peripheral field loss. And then there is typical appearance of the fundus. Typical triad is there. There is optic disc which is pale in color, right? And then you see the retinal vessels, they have become so thin, the arterioles are attenuated, they are not even visible. And these black colored pigment clumps, they are called as bony spicule pigment. So these three classical clinical features, pale disc, attenuated arterioles, bony spicule pigmentation, so they will mark the diagnosis of retinitis pigmentosa. They will mark the diagnosis of retinitis pigmentosa. So patient with night blindness, ring scotoma and this kind of fundus picture, diagnosis is retinitis pigmentosa. And how will you confirm the diagnosis? The investigation of the choice is ERG. ERG. ERG stands for electroretinogram. Electroretinogram. Okay, is that fine? So this was another important fundus case scenario which can be asked in your exams. Right. So after this we move on to an important tumor which is often asked in exam. Again the question is there almost in every exam, and that is your, my friends, retinoblastoma. Retinoblastoma. So let's revise important points for retinoblastoma. So we know retinoblastoma is the most common intraocular malignancy of children. The gene which is involved in development of retinoblastoma is present on 13q14 location, retinoblastoma gene. The mutation in this gene leads to development of the tumor. This tumor can be heritable, that is, it is passed to the offspring, but only 40% cases, 60% cases are non-heritable, right? The most common presentation, now this is very important, the most common clinical presentation of retinoblastoma is leukocoria. I'll show you the image. Leukocoria or white pupillary reflex. Leukocoria or white pupillary reflex. Okay. And then in the histological features, a typical specific feature of histopathology of retinoblastoma is what is known as Flexner-Winter-Steiner rosette. So again, I will be showing you the image. So these are the important points which I have highlighted here. Okay. So then they can ask you, like, what are the features of the question? They can be based upon the heritable and non-heritable retinoblastoma. So let's revise this. Now in heritable, see, the mutation is germline mutation. So that is why it is passed to the offsprings. So this 40% is not needed here. So it's a germline mutation. The first mutation occurs in the gamete. The second mutation occurs in the retinal cell. Now, since it is a germline mutation, the tumor is often multifocal and bilateral. It can be bilateral. It is passed to the offsprings. The patient has risk of developing secondary tumors, most commonly osteosarcoma. And sometimes these patients, they can also have the tumor of the pineal body, which is called pinealoblastoma. And when it is bilateral retinoblastoma with pineal blastoma, the condition is also known as trilateral retinoblastoma. So this is what will be seen in heritable type of retinoblastoma. Okay. Now about the non-heritable. In the non-heritable, friends, the mutation is somatic. First mutation is also in retinal cells. The second mutation is also in the retinal cells. So the tumor is unifocal and unilateral. It cannot be passed to the offsprings. And there is no risk of secondary tumors. No risk of secondary tumors. Okay. Now this, when we talk about first mutation and second mutation, now this hypothesis was given by, or it is also known as Knudsen's two-hit hypothesis, that there has to be two mutations in the gene for retinoblastoma to occur. Okay, so again it can be a question. So this is called Knudsen's two-hit hypothesis. Okay, right? So after that, as I told you, in the clinical presentation, the most common presentation is leukocoria. So this can be asked as an image question. Also, it can be asked as a case scenario. That they tell you that a parent brings a child who is having white pupillary reflex, or who is having this image. So you see, in this eye, the pupillary reflex is normal, but in this eye, you see the white pupillary reflex, which is known as leukocoria. Leukocoria. Okay. The second common presentation is the child can also have strabismus or squint. Okay. So there can be, the most common is leukocoria, and the second common is strabismus or squint, right? And on the fundus examination, Again, they can tell you in the case scenario that on the fundus examination, a cauliflower-like mass is seen growing in the vitreous cavity. So this can be the clinical feature which they give in the form of the image or in the form of the case scenario. Then your diagnosis becomes retinoblastoma, that a child brought with leukocoria, on examination the cauliflower-like mass is seen, and the third thing is the calcification, the presence of calcified mass, calcification. Again, all these three features, they go in favor of retinoblastoma, friends. Okay, leukocoria, cauliflower-like mass, calcification seen in the tumor. Okay, so please remember this. Then when they do the histopathology, supposedly the eye is enucleated, the specific histopathological feature of the retinoblastoma, as I just told you also, is Flexner Wintersteiner rosettes. Flexner Wintersteiner rosettes, which are specific of retinoblastoma. They are specific of retinoblastoma. So again, this can be asked as the image. You see the tumor cells. The tumor cells, they are arranged in the rosette-like manner. So these are your Flexner Winterstein rosette. Please remember this image. They are specific of retinoblastoma. Okay, friends? Right. So then in retinoblastoma, another thing to remember is in the treatment part. In the treatment part, that what are the treatment options available? What are the treatment options available? Now, in the treatment options available, we have different options. We have the focal therapy. The focal therapy which can be done with the help of the laser in the form of the cryotherapy, or even in the form of the thermotherapy for the small tumors. Okay. Then we have the chemotherapy. In the chemotherapy, the drugs which are used are VEC, that is, we use vincristine, we use etoposide, and we use cisplatin. No, we use carboplatin here. Carboplatin. Okay. Then for the large tumors, we do enucleation. Enucleation for the large tumors. And if the tumor has spread to the orbit or optic nerve invasion, then we do the radiotherapy. When the tumor has spread to the orbit or optic nerve invasion, then we do the radiotherapy. Okay. Now going where we do that, so in the clinical case, how they can ask you. Now there is an international classification of the retinoblastoma, international classification of retinoblastoma, that is ICRB, according to which, depending upon the size of the tumor and location of the tumor, it has been divided into different groups. Group A, B, C, D and E. Okay. So group A and B are the small tumors, right? Group C and D, they have the seedings. Group E is the advanced tumors. Okay. So for the group E, the treatment is enucleation, because it is advanced tumor involving more than half of the globe or anterior segment involvement. Then enucleation is the treatment. So please remember E for group E and enucleation for the tumor. Okay. And from group A to D, we can go for focal therapy, as we discussed, plus minus chemotherapy, because chemotherapy can help in reducing the size of the tumor, and then you can do the focal therapy to the reduced tumor. Okay, so for the management part, the easiest way to remember is, if the tumor is group E, that is, it is large advanced tumor, anterior segment involvement, then enucleation, removal of the eyeball. Between group A to D, you can do the focal therapy plus minus chemotherapy. If the tumor is sometimes large but not group E, it can be reduced in size by chemotherapy, and then we can give the focal therapy. Okay, so these are the important points to be remembered about the retinoblastoma. Okay. Okay, so then we can move to the another topic, that is uvea, and what to revise and remember about the different conditions which are part of the uveitis. Okay, so in the uveitis, because uveitis is the inflammation of the uvea, uveitis is the inflammation of uvea, and we know the uvea has, like, there is anterior uveal area, that is the iris and the ciliary body part, then we have the pars plana area, then we have the choroid area. So depending upon different involvements, the different type of uveitis is there. And what are the clinical features of these? What are the important conditions here? Let's revise those, friends. Now in the uveitis, so first of all you have to know that what are the clinical features, because this can again be asked as an image question or as a case scenario question. Image question or a case scenario question. So what can be the clinical features? So again, there will be redness. If a patient presents with redness, pain, photophobia, and decreased vision, right? See, so these are the conditions. I am talking about anterior uveitis. So these are the features of anterior uveitis, friends. If a patient presents with redness, pain, photophobia, decreased vision. Now here, how to differentiate it from the corneal ulcer? In corneal ulcer, if you remember, there is discharge, and when you see the image, there will be seen, the corneal changes will be there. But here, if you see the image, the cornea is clear, right? So you will, and what will you see in the image? What will be able to, how to make a diagnosis? You see there is the congestion. You can notice that the pupil is irregular. Pupil is irregular. This irregular pupil, if you see in a case which is showing red eye, irregular pupil, hypopyon can be there, and with the case history of cornea is clear, with the case history of redness, pain, photophobia, decreased vision, so it can be a case of anterior uveitis. Okay, so especially when you notice irregular pupil, which is due to posterior synecdoche, red eye, clear cornea, cornea is fine, it means the inflammation is in the uvea. So then you can make a diagnosis of anterior uveitis. Anterior uveitis. Okay. Now in anterior uveitis, what other features they can be seen? What other features they can be seen? You can see these deposits at endothelium of the cornea, that is back of the cornea. These deposits, they are called as capes or keratic precipitates. They are again features of anterior uveitis, capes or keratic precipitates, right? So these capes, they can be fine, that is small in size. They can also be big. When they are big, they are called mutton fat capes. When they are big, they are called mutton fat capes. And mutton fat KPs, they are feature of granulomatous uveitis. Depending upon the pathological type of the inflammation can be granulomatous in nature or non-granulomatous in nature. So big size or mutton fat KPs are seen in granulomatous uveitis. So all these, they can be asked as your question. So KPs are pathognomic of uveitis. They are specific of uveitis. And mutton fat KPs are seen in granulomatous uveitis. Okay, right? Then another feature, as I showed you in the previous image also, is the irregular pupil. The irregular pupil is due to posterior synecdoche. The irregular pupil is due to posterior synecdoche. The posterior synecdoche are the adhesions of the iris and the lens. So they are also seen in uveitis. Okay. Then another feature which we can see is the appearance of the iris nodules. Appearance of the iris nodules. There are two types of the iris nodule. One are called as Busseca nodules, other are called as Coip nodules. Now Busseca nodules, they are present, you see here, in the body of the iris. Busseca, body of the iris. Right? And Coip nodules, they are present at the pupillary margin. Pupillary margin. So P, pupillary margin. So these iris nodules, please remember the name. There was an exam question last time that Coip nodules are seen in, or Busseca nodules, they are seen in. They are iris nodules. They are seen on the iris. And they are a feature of granulomatous uveitis, friends. Granulomatous uveitis. Okay. So again, important point to remember. They are feature of granulomatous uveitis, iris nodules. Okay. You will remember this. Then there are certain arthritic conditions which are associated with uveitis. In that, the most common is ankylosing spondylitis. Ankylosing spondylitis. Then we have Reiter syndrome and psoriatic arthritis. Now these three, ankylosing spondylitis, Reiter and psoriatic arthritis, are HLA B27 associated. They are associated with HLA B27. In ankylosing spondylitis, as you know, it can come as a case scenario. We know in ankylosing spondylitis what happens? There is sacroiliitis, involvement of the lumbosacral spine. So the patient can present with low backache. There will be feature of sacroiliitis. So when in the history these features are there, a patient having red eye, decreased vision, also having low backache, sacroiliitis, so then the diagnosis becomes ankylosing spondylitis. So this kind of case scenario can be there. Okay. And in juvenile rheumatoid arthritis, the point to be remembered about juvenile rheumatoid arthritis is it is your pauciarticular seronegative type of the juvenile arthritis which causes the uveitis. Okay, pauciarticular seronegative type. And this is one condition in which intraocular lens is contraindicated. because the inflammation is very, very severe. If a patient of juvenile rheumatoid arthritis develops cataract, you do cataract surgery, but you do not put intraocular lens. Intraocular lens is contraindicated. Okay. So these were few important conditions of anterior uveitis. Now coming to few important other uveitic conditions. So one which we must know is toxoplasma. Toxoplasma. Now in toxoplasma, a typical feature which is seen, the fundus appearance which is seen, is known as headlight in fog appearance. Headlight in fog appearance. Okay, as you are noticing here. So what you are seeing here is, this is an area of retinitis or retinochoroiditis, the inflammation of the retina, and then there is vitreous inflammation which leads to haziness. Vitreous inflammation which leads to haziness. Okay, so this typical appearance is known as headlight in fog appearance. I should mention it, retinochoroiditis, not only retinitis, right? So toxoplasma, remember, headlight in fog appearance. So when it heals, it leaves this kind of scar. It leaves this kind of scar which is known as punched out scar. Now this is known as punched out macular scar. Okay. So please remember this. Toxoplasma, remember, in the active stage, it has headlight in fog appearance. When it heals, it leaves out punched out macular scar. Then there is a condition which is known as, this can again be asked as an image based question, which is known as CMV retinitis. CMV retinitis means cytomegalovirus retinitis. In this, again you see there is a retinal inflammation and there are also hemorrhages. So this gives a typical appearance. This gives a typical appearance which is known as pizza cheese appearance. Pizza cheese appearance, which is a sign of cytomegaloretinitis. So it is usually an opportunistic infection in HIV. It is usually an opportunistic infection in HIV. So remember, CMV retinitis, pizza cheese appearance, they can show you this image. They can show you in the history that the patient is HIV positive. So you can make a diagnosis of CMV retinitis. Is that fine, friends? Okay. Then another condition which they can ask you is VKH disease. Vogt-Koyanagi-Harada disease, VKH. Now this can be asked as a case question. They can ask you. Now in this there are ocular features, there are neurological features and cutaneous signs. So they can ask you that the patient is having sunset glow fundus or panuveitis with vitiligo, alopecia, which are the cutaneous signs here, and tinnitus, the neurological features. So if there is a history of vitiligo, alopecia, tinnitus along with panuveitis, then it can be a case of VKH. And remember two signs in VKH. One is your sunset glow fundus, that the retina appears like a sunset kind of glow it gives. And then there is a one sign which is known as Segura sign. Segura sign is that in the perilimbal area there is lack of pigmentation, vitiligo, perilimbal vitiligo. So this is again a sign of VKH disease, VKH disease. Okay. Then moving on to another uveitic condition which is called as sympathetic ophthalmitis. Sympathetic ophthalmitis. Now, in sympathetic ophthalmitis, the points to be revised are, so number one, it is inflammation in both eyes, in both eyes. After injury, now this injury can even be intraocular surgery, but this injury has to be having a penetrating wound, that there should be penetrating injury, not the blunt trauma. Okay? And specifically when the injury involves ciliary body area, friends. So that is why ciliary body area is also known as dangerous area of the eye, because when the wounds they involve ciliary body area, the chances of developing sympathetic ophthalmitis are high. And because it involves both eyes, so there can be risk of loss of vision in both eyes. The injured eye is called the exciting eye, and the normal eye which develops inflammation, as you remember, is called as sympathizing eye. Okay. Now in sympathetic ophthalmitis, again I am highlighting these 2 points. Penetrating wound is essential. Okay. Now what are the features which you see? They can ask you a question. It is a granulomatous type of uveitis, panuveitis occurring in both the eyes. So please remember, involving both the eyes, granulomatous type of inflammation and panuveitis type of inflammation. Usually the onset is 2 weeks after the injury, not immediately. The earliest symptom which you will note is the weakness of the accommodation. So weakness of the accommodation means the patient will have difficulty in near vision. The patient will have difficulty in near vision. So that is the earliest symptom. The patient can also have photophobia. And what is the earliest sign of sympathetic ophthalmitis? That is retrolental flare. Retrolental flare is the earliest sign of sympathetic ophthalmitis. And a specific feature which is seen in the fundus is Dehlen-Fuch nodules. So all these, they can be asked as one-liner questions. Dehlen-Fuch nodules are seen in sympathetic ophthalmitis. Right? And what is the treatment? What is the treatment? So treatment is in the form of steroids, and if you suspect that it is going to develop sympathetic ophthalmitis, that the injury is very severe, then enucleation of the injured eye. Enucleation of the injured eye, friends. Okay. If the injured eye cannot be surgically repaired, then enucleation of the injured eye. Okay. So these were the important uveitic conditions based upon which they can ask you the questions, which we have revised already. So coming on to the important points in the neuro-ophthalmology. Important points in the neuro-ophthalmology, friends. Right. Okay. So in neuro-ophthalmology, the condition first of all we will be revising is what is your optic neuritis. Optic neuritis. So we are talking about the inflammatory diseases. So continuing, when there is inflammation of the optic nerve, when there is inflammation of the optic nerve, that is called optic neuritis. Right. Now this optic neuritis we know can present as, because whether optic nerve head is involved or part of the optic nerve behind the eyeball is involved, or nerve plus macula is involved, so it can be papillitis. Papillitis, okay. So in papillitis you will see that there is optic disc swelling and hyperemia. But when the part of the optic disc behind the eyeball is there, then it is called retrobulbar neuritis. In retrobulbar neuritis, fundus examination is normal. Now this is very, very important. Fundus examination is normal in retrobulbar neuritis. Why? Because it is the optic nerve behind the eyeball which is involved. Okay. Then the last is your neuroretinitis, in which both disc swelling plus macular edema is there. So that is neuroretinitis, that the nerve as well as macular part of the retina is involved. Okay. And what is the most common cause of optic neuritis? That is multiple sclerosis. Multiple sclerosis, which is a demyelinating disease. Which is a demyelinating disease. Right? So depending upon the presentation, papillitis, retrobulbar neuritis, this is very important point. In retrobulbar neuritis, the sign of loss of vision, etc. will be there, but fundus examination will be normal. Right? Now, what are the signs and symptoms of optic neuritis which you will see? The patient will always have decrease in vision, and very important, there will be pain on ocular movement. So if in the case scenario, because this can come as a case scenario, that a patient presents with decreased vision, which is painful or pain on ocular movements, there is defective color vision, there is Marcus gun pupil, or what is also called as RAPD, right? So these all they indicate towards optic neuritis. Whenever there is optic nerve involved, there will be visual field defect. Now this visual field defect can be in the form of central scotoma or centrocecal scotoma. Again, it is a feature of optic neuritis. And I have highlighted once again here that fundus examination is normal in the cases of retrobulbar neuritis. But you will see the above features. So what will be the case scenario? That there is a lady who presents with pain, decrease in vision, there is pain on the ocular movements, RAPD is present, but fundus examination is normal. So what is your diagnosis? Your diagnosis will be, there is only one condition in which there will be RAPD, decreased vision, but normal fundus examination, and that is your retrobulbar neuritis. Retrobulbar neuritis. Okay, right? So this is what is important from the optic neuritis part. Coming on to very important topic, visual field defect. Please be attentive here, because visual field defects, again, normally one question is there from the visual field defects, right? Okay. Right. So coming on there on the visual field defects, before we move on to the visual field defect, let me revise with you the different parts of the visual pathway. Different parts of the visual pathway. So as you know, friends, the visual pathway starts from the retina. From the retina arises your optic nerve. Okay. Now this optic nerve ends at optic chiasma. And as we know, at optic chiasma, the nasal fibers as you are seeing here, they are crossing on the opposite side. The temporal fibers, they pass on the same side. So at the optic chiasma, there is crossing of the nasal fibers. Okay. Then beyond optic chiasma is your optic tract. The optic tract ends at lateral geniculate body. From lateral geniculate body, the optic radiations, they start. The optic radiations, some radiations, they pass through parietal lobe. Some radiations, they pass through the temporal lobe. And then they end at occipital cortex. They end at occipital cortex. So this is the visual pathway. Now whenever there is injury at any level of visual pathway, that will cause the visual field defect. That will cause the specific visual field defect, which we are going to revise now. Now, If the lesion is in the macula, if the lesion is in the macula, so that will lead to central scotoma, okay, like this. If the lesion is on the optic nerve, if the lesion is on the optic nerve, so that will cause monoocular vision loss on the same side of the optic nerve, okay. Then if the lesion is in optic chiasma, central area, because that is the common lesion there. Now central chiasma has nasal fibers. So since it has nasal fiber, the visual loss which occurs is bitemporal hemianopia, as you remember, okay. So central chiasma, optic chiasma lesions, they will cause bitemporal hemianopia, okay. Then when the lesion is at optic tract, then it causes homonymous hemianopia contralateral. Contralateral means if the lesion is on the right optic tract, so as you see here, the left side field is gone. So contralateral, homonymous hemianopia, okay. Now if the lesion is in temporal lobe, there is superotemporal quadrantopia. This is also called pie in the sky quadrantopia. Superior quadrantopia, again on the opposite side, contralateral, and it is also called pie in the sky. If the lesion is in the parietal lobe, it is inferior quadrantopia, contralateral, and it is called pie on the floor. And lastly, if the lesion is in the occipital cortex, so that causes homonymous hemianopia with macula sparing. Now this is very important, that the macular area, you see this central area is spared. So homonymous hemianopia with macula sparing, okay. So you have to remember these very beautifully. It has been shown in this diagram and I have labeled it also. So please do remember which is the type of the field defect and which is the site of the lesion, my dear friends, okay. Now in this, an important case scenario can be asked regarding the visual field defects, that a patient having headache, amenorrhea or menstrual irregularities, galactorrhea, okay. So this kind of the patient presents with bitemporal hemianopia. So they can ask you what is the site of the lesion or what is the diagnosis. Now bitemporal hemianopia, we just learned, is seen in when the optic chiasma lesion is there, the central area. Now this area is related to your pituitary gland. So these features, menstrual irregularities, galactorrhea, they are usually feature of pituitary adenoma. So question can be related to this. Either they can tell you that a patient with pituitary adenoma, what kind of field defect will be there. So that will be bitemporal hemianopia. Or they tell you a features and they ask you what kind of field defect is suspected, that will be bitemporal hemianopia. Similarly, in the tumors of the craniopharyngioma, again another pituitary tumor, so that can also cause bitemporal hemianopia. So please remember, this can be asked as the case scenario also. Okay, right? Right. So then another important condition, now we are going to discuss some important conditions of the pupil, right? So one is your RAPD or Marcus Gunn pupil. RAPD or Marcus Gunn pupil. So what is RAPD or Marcus Gunn pupil? It is seen in the cases of optic nerve or retina diseases, optic nerve or retina diseases. So normally if you flash light on the pupil should constrict. But if the pupil dilates in response to the light, so that is known as RAPD. Okay. So this test you see here, on the normal side, the light comes to the eye, the pupil is constricting. But when you flash the light, when you swing the light to the abnormal side, the pupil is dilated, it remains dilated. So this is feature of Marcus Gunn pupil or RAPD, and this test is known as swinging flashlight test. This test is known as swinging flashlight test. Okay, RAPD or Marcus Gunn pupil. Then another abnormality of the pupil is what is known as Argyll-Robertson pupil. Argyll-Robertson pupil. Now this is ARP. So what happens in Argyll-Robertson pupil? The pupil does not react to light. When you bring the light source, the pupil does not react. But when you bring a near target, when accommodation reflex comes into play, then the pupil reacts briskly. So pupil reacts to accommodation, but pupil does not react to light. So that is AR pupil. How you remember? Accommodation reflex, A, accommodation reflex present, but light reflex absent. Okay, when the light reflex is absent but accommodation reflex is present, that is ARP, Argyll-Robertson pupil. So this is how you remember. Okay, then another condition is your Horner syndrome. Horner syndrome. Now what happens in Horner syndrome? In Horner syndrome, actually friends, there is what we call as oculosympathetic paralysis. Oculosympathetic paralysis. Okay. So what is happening here? So what is happening here is, in the eye, we know the dilator pupillae muscle. The dilator pupillae muscle is supplied by the sympathetic system. So this muscle is now not acting. So you see there is small pupil. So what are the features? There is miosis. Then there is mild ptosis. There is mild ptosis and anhidrosis. That is lack of sweating is there. And another feature is that the eye appears apparently having anophthalmos. We call it as apparent anophthalmos. Okay, so Horner syndrome, oculosympathetic paralysis, miosis, mild ptosis, anhidrosis and apparent anophthalmos. Because the dilator pupil is not acting, so what happens? The pupil does not dilate in dark. Does not dilate in dark. So that is a feature which you will see in Horner syndrome. in Horner syndrome. So these were the important pupillary abnormalities. Pupillary abnormalities. Okay. So now we move on to the revision of the squint, the important squint and the nerve palsies. Right? Okay. So for the squint and the nerve palsies, beta, just have a quick look at this figure which tells you the different extraocular muscles, so that you get to know that how these muscles are moving the eyeball. We know that there are 4 recti. So we have 4 recti, 2 oblique muscles and levator palpebrae superioris, which moves the upper eyelid. So all these muscles, they are the recti and oblique, they are called as extraocular muscles, which are responsible for the extraocular movement. Okay. Now these muscles, they perform different actions. Okay. Some muscles, they have only primary action, like medial rectus and lateral rectus. Medial rectus causes adduction, inward movement of the eye. Lateral rectus causes abduction, outward movement of the eye. Okay. But recti and obliques, they have primary, secondary as well as tertiary actions. Okay. Now there are tips to remember this table here. Okay. So what are the tips to remember? So all obliques, that is both superior and inferior oblique, they have abduction as their action. Okay. Then all recti except lateral rectus, they have adduction as their action. Then all superior muscles, that is superior rectus as well as superior oblique, they have intorsion as their action. And all inferior muscles, that is inferior rectus and inferior oblique, have extorsion as their action. Okay. So this table will help you remembering that what are the primary, tertiary and secondary actions of different muscles. So they are important to remember. And if we talk about the nerve supply, again there is a simple mnemonic to remember that, what is known as LR6SO4O3. LR6SO4O3. So LR6 means that the lateral rectus is supplied by 6th nerve. SO4 means superior oblique is supplied by 4th nerve. O3 means that all other muscles are supplied by 3rd nerve. So 3rd nerve supplies medial rectus, inferior rectus, superior rectus, inferior oblique. It also supplies the LPS, as you remember. It also supplies the LPS. Okay. So different muscles, their actions as well as their nerve supply is important to remember. Then coming on to the squint, beta, what do we mean by squint or strabismus? The strabismus or squint is called as ocular misalignment. When the two axes of the eye, they are not properly aligned, that is called as squint. And as you know, the latent squint is called phoria. The manifest squint is called tropia. Depending upon whether the deviation is inward, outward. So if you see here, the deviation is inward. So this is called esotropia or convergent squint. Esotropia or convergent squint. Okay. Here you see the deviation is outward. So this is called exotropia or divergent squint. Okay. Here the deviation is upward. This is called hypertropia. Here the deviation is downward. This is called hypotropia. Okay, so if you see the image, whichever side the eye is deviated, esotropia, exotropia, hypertropia, hypotropia. So you will get to know that. Okay. Then we need to revise about the paralytic squint. the paralytic squint. So friends, the paralytic squint means when there is paralysis of the muscle action, which can be due to some nerve paralysis or due to the muscle problem. So in paralytic squint, there are specific features. One is your diplopia. Diplopia means double vision. So when the patient has double vision, he will have confusion. The eye movement will be restricted, whichever muscle is paralyzed, whether lateral rectus is paralyzed or superior rectus. So there will be movement restriction. And to avoid the diplopia, the patient assumes compensatory head postures, which can be your face turn or head tilt. Okay, so to avoid diplopia, the patient has different kind of compensatory head postures. Now these features are specific of paralytic squint. Okay. And in paralytic squint, they can ask you the question about the different nerve palsies. So let me show you the figures here. So first of all, have a look at this figure here. So if you notice here, friend, the eye is showing convergent squint in this side. It is showing convergent squint here. Okay. This eye is able to move out. This eye is able to move in. So this position is normal. This movement is normal. Now this eye is able to move in, but this eye is not able to move out. So it means abduction is paralyzed. So which is the muscle which causes abduction in the eye? Which muscle causes abduction in the eye? That is lateral rectus. Lateral rectus. So here, if they show you this picture, you can see since abduction is paralyzed, so it is the lateral rectus palsy. And the lateral rectus palsy will occur in the cases of course, sixth nerve palsy. So what will be the features in the sixth nerve palsy? That the patient is having convergent squint, the abduction is paralyzed, and patient will of course have diplopia. Patient will have diplopia. So these will be the features, and based upon the image you can make the diagnosis of lateral rectus palsy. Okay. Now coming to the features of third nerve palsy. Now as you know, third nerve supplies all the muscles except for lateral rectus and superior oblique. So here you will be noticing that all the muscles are paralyzed except for lateral rectus and superior oblique. Now what can be the causes of the nerve palsies? In the third nerve, the most common cause is ischemic, that is involvement due to diabetic or hypertensive changes. Third nerve can also be paralyzed due to the surgical causes, that is due to trauma or compression by tumor or aneurysms. But most commonly it is the ischemic causes. Now very important to remember, in third nerve palsy, the eye is down and out. The eye is down and out position. And there is diplopia in all the directions except down and out, because only two muscles are working, the lateral rectus and superior oblique. Because there is LPS involvement also, so there will be ptosis. The pupil, because pupillary fibers, they also come from the third nerve. So in the cases of surgical causes, the pupil is also involved. Pupil is also involved, friends. Okay. And there will be loss of accommodation, because accommodation fibers, they are also through the third nerve. Okay. Have a look at this image. They can show you this image and you have to see here. So the patient is having ptosis here. The patient is having ptosis here. Right? And if you lift the eyelid, see what is the position of the eyeball? It is down and out. It is down and out. So this is how you will identify the third nerve palsy. Third nerve palsy. There will be ptosis and the eye will be in down and out position. And if you notice, in all other gazes, the movement, they will be restricted. the movement will be restricted. Okay, and then lastly, the fourth nerve palsy. Fourth nerve is the nerve of superior oblique. So it is the superior oblique muscle palsy. Now in superior oblique muscle palsy, the eye will be hyperdeviated. There will be hypertropia. The patient will have head tilt in the opposite direction. So please remember these features: head tilt in the opposite direction. There will be limited depression in adduction, that the patient cannot move the eye down, and there will be diplopia, which is worse on looking down. So hypertropia, limited depression in adduction position, and head tilt to the opposite side are the features of superior oblique palsy. Okay, is that fine? Right. Okay, so we move on to next this thing, image here. So please have a look at this image, beta. This image is of Titmus fly test. If you remember, we have discussed in our classes, this Titmus fly test is done for the stereopsis, to check the stereopsis. Right. So if you see this image in which this fly is there, there are Polaroid glasses. So please remember, this is the image of Titmus fly test, which is test for stereopsis. Then another important condition is what is known as amblyopia. Amblyopia. So what is amblyopia? Remember, amblyopia is the suppression of the vision. Suppression of the vision in absence of any organic cause. Absence of any organic cause. When the eye vision has become suppressed, it can be due to strabismus, it can be due to uncorrected refractive error. Supposedly you do not do surgery for the cataract, so that can lead on to the suppression of the vision. Now important is, what is the treatment of the amblyopia? The best treatment of amblyopia is your occlusion therapy, friends. Occlusion therapy, or what is also known as patching of the eyeball. The patching of the normal eye to stimulate the vision in the suppressed eye. Patching of the normal eye to stimulate vision in the suppressed eye. Another is penalization, that is you put atropine in normal eye, which again will blur the vision and stimulate the suppressed eye. Or you can do certain vision exercises, what is known as active vision therapy. But if they ask you the best treatment for amblyopia, your answer will be occlusion therapy. Occlusion therapy. Okay, right? So we come to the last part now, beta, about our discussion. What has happened to this? Just give me a second here. I think my laptop has become Friends, let's have a break of 5 minutes, okay, 5 to 10 minutes, and then we will resume the last part. Okay. Okay, so welcome back after this short break. So regarding just about amblyopia once more. So as I was discussing with you, amblyopia, you should know what is amblyopia. That is suppression of the vision in the absence of any organic cause. And which is the best treatment for amblyopia? That is patching of the normal eye. Patching of the normal eye so that the vision in the suppressed eye is stimulated, okay, which is known as occlusion therapy. Occlusion therapy. So in squint, mostly the questions will be asked based upon the nerve palsies as we discussed, amblyopia. They can ask you the action of the different muscles as I told you. So these are the expected questions for the squint there, right? So now we move on to the next part of our revision, which will include the important conditions of the lids, adnexa and orbit. So most of these questions are based upon the image based question and certain characteristic feature of certain conditions. So let's begin our revision of lids and adnexa. So coming here, friends, so have a look at this image there. Okay, have a look at this image there. So what we notice here? What we notice here? You notice here that the lashes, the eyelashes are interned. Eyelashes are interned. So interned eyelashes, or which are also called as misdirected eyelashes. Now this condition is known as trichiasis. Okay, so they can be asked as one-liner question, what is trichiasis? So that are interned eyelashes or misdirected eyelashes, or they can show you an image and ask you that identify the condition, this is trichiasis. Then have a look at the second image here. Here what we are noticing that there is this normal row of the eyelashes and then there is an extra row of the eyelashes. Extra row of the eyelashes. Now this condition, friends, is known as dystichiasis. Dystichiasis. Dystichiasis means extra row of eyelashes. Extra row of eyelashes. Now this extra row of eyelashes is arising from meibomian orifices. That is opening of the meibomian glands. This is arising from meibomian orifices. So this can be a one-liner question. Dystichiasis, extra row of eyelashes which are coming from meibomian orifices. Okay, right. Then have a look at this image now. Have a look at this image now. Here if you notice carefully, it is not only the eyelashes which are interned, but whole of the lid margin. Okay, so have a look at the lid margin here, and here you see the lid margin is interned. So when there is interned lid margin, so that is known as entropion. Again, this can be asked as an image question. This can be asked as an image question. Interned lid margin. So that is called as entropion. So difference is in trichiasis, eyelashes are interned. In entropion, lid margin is interned. Another thing which we need to revise, which is important for exams, is they can ask you the surgeries for entropion. We just need to remember the names. It is a little bit of cramming, I understand, but that is what we just need to know. The surgeries for entropion. So please remember the name of the procedure, friends. Jones procedure, Weiss procedure, Quicket procedure, Wheeler procedure. So these are the surgeries done for entropion. Okay. Now another condition which is reverse of entropion is ectropion. Ectropion. Again, this can be asked as an image question. So ectropion is, have a look here, this lid margin is normal, and if you have a look at this lid margin, it is outward turning of the lid margin. Ectropion is outward turning of lid margin. Okay, outward turning of lid margin is ectropion. Again, from exam point of view, the surgical procedures for ectropion are important. Please remember the names: medial conjunctivoplasty, modified Cone procedure, VY procedure, lazy T procedure, Z plasty. So just the names are required. Ectropion, image and the names of the surgeries, beta. Okay. Then two important inflammatory conditions of the eyelid, okay, and how to differentiate those. Let's revise this. So first of all, if there is a case scenario in which the patient presents with, please have a look here, the patient presents with painless nodular swelling of eyelid which is away. So every word is important. Painless nodular swelling of eyelid which is away from eyelid margin, which is away from eyelid margin. Okay, so you see this nodular swelling which is away from eyelid margin, painless, then this is clesion. This is clesion. Okay, because it is non-infective condition. It is non-infective condition and it involves the meibomian glands which are away from the lid margin. So it is clesion. Okay, so the second scenario is painful lid swelling involving lid margin. Painful lid swelling involving lid margin. So as you see here, so here is a swelling which is involving the lid margin. We can even see a pus point here. We can even see a pus point here in relation to the hair follicle, that is the eyelash. So this is your stye. This is your stye, or what is also known as hordeolum externum. Now this is the infection of glands of Zeiss which are present in relation to the hair follicle, the eyelash. Okay, so two conditions, two swellings of the eyelid, but different presentation, different features. Hordeolum externum is stye which will be at the lid margin in relation to the eyelash. Painful, you can see the erythema, the redness. The clesion will be painless nodular swelling away from the lid margin. It is non-infective. It involves meibomian gland. Okay. Then of course the clesion can also become infected. If there is infection in clesion, then it is called hordeolum internum. So that is the third condition, beta. So clesion, hordeolum externum or stye. The third condition is hordeolum internum when clesion becomes infected. When clesion becomes infected, then it is called hordeolum internum. Okay, so you will remember this because this is asked in the exam and you have to identify, differentiate between clesion and stye. Okay, right. Then moving on to have a look at this picture here and make a diagnosis. So this can again be based upon the image question. Have a look here. So what do we notice here? You notice this eye is appearing normal, but in this eye you notice the eyelid is drooped. So this is drooping of the upper eyelid, and this condition is known as ptosis. ptosis. So they can ask you based upon the image that identify the diagnosis. So if you notice that there is drooping of the eyelid in one eye or in both eyes depending upon, so that is your ptosis. That is your ptosis, drooping of the eyelid. Now there can be different surgical procedures. Now ptosis we have already learned, it can be congenital, acquired, even in third nerve palsy there can be ptosis. So for the revision point of view, we need to know what are the surgical procedure for the ptosis. Now the surgical procedure for the ptosis which you need to know, there are three procedures which are done depending upon the severity of the ptosis. First is your Fasanella Servet procedure. So Fasanella Servet procedure is done for the cases of mild ptosis, friends. Okay. Then levator resection is usually done for moderate ptosis, in which the muscle action is good. Then third is your frontalis sling surgery or frontalis suspension, which is done for the severe ptosis with poor LPS action. Okay. So again remember, mild ptosis for Fasanella Servet procedure, moderate ptosis, levator resection in the cases when there is good levator action. If there is severe ptosis with poor levator or LPS action, we will go for frontalis sling surgery or frontalis suspension. Then in ptosis, another point which we need to revise is what is known as complicated ptosis. And this was also one of the question in one of the past exam. The complicated ptosis, one type is your Marcus-Gunn synkinetic ptosis, which is also known as Marcus-Gunn jaw winking phenomena. Marcus-Gunn jaw winking phenomena. Now what happens here? There is an aberrant connection between the fifth nerve which moves the pterygoid muscles, that is movement of the jaw, and the third nerve which moves the LPS, which supplies the LPS. So in this condition what happens, have a look here. So here you see the patient is having ptosis here, the child is having ptosis here. Now when you ask the child to move the jaw, right, or when the child is swallowing or sipping the fluids, when there is jaw movement, the ptosis improves because there is synkinetic movement of the jaw muscles and the LPS. So this is Marcus-Gunn. It is also called Marcus-Gunn synkinetic ptosis or Marcus-Gunn jaw winking phenomena. So this can be asked in your exam also. Then another important condition which they have been asking lately in the exam is your myasthenia gravis. Myasthenia gravis. So in myasthenia gravis, we know the problem is at neuromuscular junction. Neuromuscular junction. Okay. Now in the eye, the myasthenia gravis, the first eye sign in myasthenia gravis is ptosis. The first involvement is in the form of the ptosis. But this ptosis, very important to hear here beta, concentrate, this ptosis is variable, that it keeps on changing. It may be less in the morning, more during the daytime, more in the evening, because it is related to the fatigue of the muscle. It is variable. It can be even like, intermittent, asymmetrical between the two eyes. So whenever there is variable ptosis, please keep myasthenia gravis as a diagnosis. Myasthenia gravis as a diagnosis. Okay. Then it can also be associated with diplopia, which is again variable, intermittent because of the extraocular muscle involvement. So when these signs are present, it means it is myasthenia gravis. Okay. And for the diagnosis, two specific tests are done. One is known as IcePack test. And the second is known as Tensilon test. ice pack test and tensilon test. Now these two tests, that when you apply the ice pack to the eye, okay, the ptosis improves. You see here the patient is having ptosis. If you apply the ice pack, the release of the acetylcholine is increased at the neuromuscular junction, the ptosis improves. Similarly, if you inject tensilon, that increases the neuromuscular activity at the junction, the ptosis improves. So if there is improvement of the ptosis on ice pack test or tensilon injection, so then it again confirms the diagnosis of myasthenia gravis. So please remember these two features about myasthenia gravis: variable asymmetrical ptosis as well as diplopia. Getting better on ice pack test or tensilon test, the diagnosis is myasthenia gravis. Okay, right? Fine. So then we move on to the tear film, the revision of the tear film and the dry eye, because again an important topic. So in the tear film, as we know, a healthy tear film is responsible for the clear vision. And the tear film has three components. It has the outer one, lipid layer, which is secreted by the meibomian glands. The middle one, aqueous layer, which is secreted by the lacrimal gland. And the innermost mucin layer, which is secreted by the conjunctival goblet cells. Okay, so lipid layer by meibomian glands, mucus layer which is secreted by the conjunctival goblet cells, and the aqueous layer which is secreted by the lacrimal glands. Now when there is deficiency of the tear film, so when there is deficiency of the tear film, that leads to dry eye. Deficiency or instability of the tear film, that leads to dry eye. Now in the dry eye, this can be asked as a case which was there. Now as I told you, the normal tear film is responsible for normal vision. So patient can be having the symptoms of grittiness, decreased vision or blurred vision, history of long hours computer work for long hours. So these cases, this can lead to dry eye. So these are the symptoms of dry eye, that there is no refractive error. Okay, no refractive error, but blurred vision, eye fatigue, long work on the computer, so that can lead to dry eye. So this will be making a diagnosis of dry eye. Now have a look at this image. So this can be asked as an image question also, that identify the test which is being done here. So there is a paper strip which has been put, and if you remember in the class also we have discussed, this is your Schirmer's test. This is your Schirmer's test, which is the test for the dry eye. This is your Schirmer test, which is the test for the diagnosis of the dry eye. And what will be the treatment of the dry eye, friends? What will you suggest if you diagnose a case of dry eye? Lubricant eye drops, because you want to keep the eye surface moisturized. So you will use lubricant eye drops for the treatment of the dry eye. Okay, so please remember what can be the features in the dry eye: Schirmer's test, the treatment of the dry eye, lubricant eye drops. Okay, right? Okay, now there can be dry eye, as we just learned, or there can be excessive watering from the eyes. Now in excessive watering from the eyes, one of the causes in children can be congenital NLDO, that is congenital nasolacrimal duct obstruction. Okay, so nasolacrimal duct is the one which drains the tear film, the tears which are being produced. Okay, so if there is failure of canalization of this duct by the end of the gestation, the child will be having watering because the tears, they are not being drained. Usually the site of the obstruction, it is the end of the nasolacrimal duct at the level of valve of Hesner. So the child will be presenting with, the parents will be bringing with, the child is having epiphora or watering of the eyes. Okay. Now this is how they will be bringing the child. Now what will be the treatment? Now this is important for your exam. The treatment of the congenital nasolacrimal duct obstruction. The question have been asked repeatedly, beta, have a attention here. Treatment will depend upon which is the age group of the child. If the age is till 9 months, we suggest the Krigler massage, or what is also called as sac massage. Krigler massage or sac massage. If the age group is between 9 months to 4 years of the age, we suggest syringing and probing of the nasolacrimal duct. Syringing and probing. And once if the symptoms, they are still present and the child is now more than 4 years of the age, then we do the procedure of DCR. Then we do the procedure of DCR, in which we make an anastomosis between lacrimal sac and middle meatus. DCR means dacryocystorhinostomy, that a new opening is made by causing an anastomosis between the lacrimal sac, and this new opening now opens in middle meatus. So please remember, the treatment of congenital NLDO will depend upon what is the age of the child. What is the age of the child? Okay. And if it is an adult patient and who is having the nasolacrimal duct obstruction, we can go straight forward with the DCR. Right? Okay. Then coming on to the important conditions which we need to revise for the orbit. Right? So in the orbit, few terminologies I want you to revise with me. One is beta, what is known as proptosis, what we call as proptosis. So this can be one-liner question. Proptosis means protrusion of the eyeball, the forward displacement of the eyeball. The measurement of the proptosis is done with a procedure what is called as eggs ophthalmometry. And the instrument which we use is usually Hertel eggs ophthalmometer. Hertel eggs ophthalmometer. Okay. Now, they can again ask another one-liner question. What is the most important, most common cause of proptosis in adults? So, most common cause of proptosis in adult friends is thyroid eye disease or thyroid ophthalmopathy. Okay. Whereas in children, the most common cause of proptosis is orbital cellulitis. Orbital cellulitis. Now, besides the proptosis, there are few features of the thyroid ophthalmopathy which we need to revise. So, first is, what is the first sign in thyroid ophthalmopathy? The first sign, friends, in thyroid ophthalmopathy is lid retraction. Lid retraction, or what is also known as Dalrymple sign. Dalrymple sign. Okay. So if you see the figure here, you see how the lids are retracted and the eyeball is protruding here. Lid retraction and proptosis. So first sign is lid retraction or Dalrymple sign. And as we remember, the thyroid eye disease also involves the extraocular muscles. So which is the most common or the first muscle involved in thyroid eye disease? That is your inferior rectus. Inferior rectus. Okay. So these points, they can be asked as one-liner question. Right? Then one condition which is often asked as a case scenario in the orbit is orbital cellulitis. We know orbital cellulitis is the infection of inflammation of the soft tissues of the orbit. So the case, how the patient will present, how the case will be there. Now this is first of all you have to remember this is an ocular emergency. So patient will have very acute symptoms. So what are the symptoms which will be there? Patient will be having fever. Patient will be having painful proptosis. Painful proptosis. Okay. So as you see here, the patient is having lid swelling, proptosis. There is conjunctival edema, or which is known as chemosis. Okay. Conjunctival edema or chemosis, as you notice here also. Okay. The extraocular movements will be restricted. Frozen eye. Okay. Extraocular movements will be restricted. There will be pupil involvement. There will be pupil involvement. And even optic disc swelling can occur. Optic disc swelling can occur. Okay. So this is an ocular emergency. The patient will come with painful swelling of the eyeball, as you see here, proptosis, conjunctival chemosis, restriction of the eye movements, and if we do not treat it, it can complicate to cavernous sinus thrombosis as well as intracranial complications. So this patient has to be hospitalized and given intravenous antibiotics. Intravenous antibiotics. So please remember, they can show you the image along with the clinical features. So this will be a case scenario of orbital cellulitis, friends. Okay, don't forget that. Then certain again one-liners based upon the orbital tumors which you should know, friends. So first of all, let's revise with me. Most common benign intraorbital tumor in children, that is dermoid. Benign intraorbital tumor in children, dermoid. Okay. Primary malignant orbital tumor in children, that will be rhabdomyosarcoma. Most common primary malignant orbital tumor in children, rhabdomyosarcoma. Okay. Then most common benign orbital tumor in adults, that will be cavernous hemangioma. And most common primary malignant orbital tumor in adults will be lymphoma. Okay. So mostly one liner they can ask you what is the common benign malignant tumor either in children or in adults. So please do remember these facts there. Right. Fine. So going ahead, beta, few important points regarding the ocular trauma and the questions which can be asked based upon that. Okay. So in this, first of all, let's see what changes can be there in blunt trauma. So this was your question in the last exam also. So blunt trauma means that there is no penetrating injury to the eye. So blunt trauma, for example, injury with the cricket ball, with tennis ball or anything, or somebody punched, fist injury, something like that. So that will be the blunt trauma. Now depending upon the severity, the blunt trauma can cause different changes. The ones which they can ask as the question and the image based question. So like this can be asked an image question. So what do you see here? So what you are seeing here, friends, is that there is iridodialysis. The iris has been separated from its root. Iridodialysis. So this leads to a D-shaped pupil. The pupil has become D-shaped. Okay. So please remember, blunt trauma can cause D-shaped pupil or iridodialysis. Similarly, already we have discussed about the rosate cataract. Another feature which can be seen on the lens is what is known as Vossius ring. If you see carefully, there is a brown pigment ring on the lens surface. Now this is called, friends, Vossius ring. Vossius ring. Okay, so this is again feature of blunt trauma. Now both they can be asked as the image question, osseous ring and iridodialysis or D-shaped pupil. Okay, please don't forget that. Then in blunt trauma, or as even in traffic injuries, there can be fracture of the orbital bones. And when there is fracture of the orbital bones, so which is the most common wall of the orbit which is involved, that is your floor of the orbit. Floor of the orbit. Okay, and this type of the fracture is called as orbital blowout fracture. Orbital blowout fracture. Again, have a look at this image. This can be asked as an image question. So this is this image, CT image, which is showing. So a typical sign is seen here because orbital contents are prolapsing into the maxillary cavity, the maxillary sinus, because the floor is fractured. So this sign is known as teardrop sign. Teardrop sign. Okay, so they can show you the image of the orbital floor fracture, how identify it by the teardrop sign. So this is picture of floor, the fracture of the floor of the orbit, which is the most commonly involved wall of the orbit, blowout fracture of the orbit. Okay, so these points about the trauma you should know, friends. After that, I'll be just quickly revising with you the images of the different exam techniques, because they can be asked as mostly as an image based question. Okay, so what we learned from the classes. So first of all, you identify this instrument, beta, this instrument. Now this instrument is your slit lamp biomicroscope. Slit lamp biomicroscope, which helps in detailed examination of the interior segment as well as the posterior segment by the use of specific lenses. So we know when we examine the eye with the slit lamp, we can see the different structures of the interior segment: cornea, iris, anterior chamber, lens, vitreous chamber. Okay, so identify this image also. This is your slit lamp biomicroscope. Okay, then for the fundus examination, we have different instruments. So this is the image of direct ophthalmoscope. Okay, have a look at this image. This is your direct ophthalmoscope. Now, direct ophthalmoscope is used for examination of the central retina. It gives a magnified view, up to 15 times magnification, and the image which we see is virtual and erect image. And they can also show you this picture that identify the procedure which is being done here. So how will you identify? For the examination with the direct ophthalmoscope, you have to come very close to the patient and look through the pupil. So when patient is being examined very closely through an instrument in one hand, very closely, so that is the direct ophthalmoscopy which is being done. Direct ophthalmoscopy. Okay. Then direct ophthalmoscope can also be used for a procedure which is called at distant direct ophthalmoscopy. Okay, so here if you see, they are looking at a distance approximately about 25 centimeter or 22 to 25 centimeter. So this procedure is your distant direct ophthalmoscopy or DDO. And where it is done? So this usually is done to look for media opacities, that whether there is any lens opacity or corneal opacity, or to check the glow. To check the glow, like if you see white reflex or dull reflex, it means there is some problem in the media, either cornea or in the vitreous or in retina or in lens. So you can use this for quick screening of the media opacities. So that is your distant direct ophthalmoscopy. Okay. And then we have the indirect ophthalmoscope. The indirect ophthalmoscope, so this is the instrument, the indirect ophthalmoscope. Now this is done for the examination of the peripheral retina. Okay, so magnification is less, but you can see a wide field of vision. The magnification is about 3 to 5 times. We get a real and inverted image, and the benefit is that you get a binocular view. You get a binocular view. Okay, so again this image can be shown to you that identify the procedure being done. So you see this instrument is worn on the head. We use a condensing lens to focus on the retina. So when you see this image in which an instrument is being worn on the head, the patient is lying down or partially tilted. So that is your indirect ophthalmoscopy. Indirect ophthalmoscopy, which is the best way to examine the peripheral retina. Okay, right? And then identify these charts with me, beta. Already we have done in our online classes. These are the charts for the distance vision. This is your Snellen's chart. Okay, so they can show you the images. You should know this is the Snellen's chart. Okay, these are the Landolt C and E charts. Landolt charts, which are for the illiterate people, C and E charts. Okay, and this is your another distant vision chart. Remember, this is your ETDRS chart, friends. ETDRS, early treatment of diabetic retinopathy study chart. How we differentiate here, every line has 5 letters. Okay, so there the letters are like, first line has 1, second 2, 3, 4 in Snellen and Landolt. In ETDRS chart, every line will have 5 letters. Every line has 5 letters. So that can help you in identifying ETDRS chart. Okay, right? And what is this? What is this? Remember, these are your Ishihara color plates. Ishihara color plates, which are done for testing color vision. So you can see these colored dots in which the numbers they are written. So if you see something like this, these are your Ishihara color plates for color vision. Okay. Then few instruments which are important as a last part of your revision, that will make everything complete for your revision. So have a look at this instrument, beta. This is your Clagion clamp and this is your Clagion scoop. Okay, so have a look here, Clagion clamp and Clagion scoop, which are used for the incision and curettage of Clagion. Okay, let me show you here so that you get to know. See, this is how the clamp is used for Clagion incision and curettage. Incision and curettage. You clamp it and then you make an incision here and scoop out the contents of the Clagion. Okay. Clagion clamp. Have a look once more. Clagion clamp and Clagion scoop. Okay. Then these are your lacrimal probes. Lacrimal probes, which are used for probing and syringing, which I just told you. Probing and syringing. They are called as Bowman lacrimal probes. Bowman lacrimal probes. Okay, right? Bowman lacrimal probes. Then, what is this? This was asked in one of the exams. This is your DCR punch. This is your DCR bone punch. Okay, because in DCR you have to make an opening between the lacrimal sac and the middle meatus. So you have to punch out this bone here. You have to punch out this bone here. So you will use the DCR punch. DCR punch. Okay, so please remember this image. This was asked in the exam also. Right? Then this is your enucleation spoon and scissors. enucleation spoon and scissor. So enucleation is a surgery, as you are having a look here beta, in which whole eyeball is removed. Whole eyeball is removed. That is your enucleation surgery. For example, in intraocular tumors, retinoblastoma. Okay, so you see whole of the eyeball is being removed. That is enucleation. So this is used to engage the optic nerve, and the scissors are used to cut the optic nerve so that you can remove the eyeball. Enucleation, spoon and scissors. Okay, and then there is another surgery which is by the name of evisceration. Now in evisceration, the middle and inner layers are removed of eyeball are removed. You leave the scleral shell. That is the difference. Like you see, you cut the corneal button, the cornea has been removed, the corneal button is cut, and then this is again a scoop here. You are removing the uveal tissue and the inner contents, but the scleral shell, the outer shell remains like that. Okay, so this is a surgery which is done usually when there is what we call as panophthalmitis. This is surgery for, so the indication of evisceration is panophthalmitis. Okay, so this is just to let you know what is the difference between enucleation and evisceration. Okay, and then the cataract surgery. In the cataract surgery, they can show you the image of what is being done here beta. What is being done here? They are making an opening in the capsule. Again, they are making an opening in the capsule. So if you remember, I had told you this is the CCC, continuous curvilinear capsulorhexis. So this is the step of capsulorhexis, making an opening in the anterior capsule. Okay, so they can also show you these steps, that how the phaco probe, this is the phaco probe, how the phaco probe is being used to break the nucleus, to aspirate the nuclear material. Okay, so if you see the phaco probe, if you see the lens being broken into the segments, you can identify that this is the cataract surgery. Okay, and this image is of capsulorhexis, capsulorhexis. And then in the last, if you see an image like this, in which there are ports, there are openings which have been made in the pars plana area, to reach the vitreous cavity. So that is your pars plana vitrectomy, if there is an image like this. Okay, pars plana vitrectomy, the different ports are made through the pars plana area to reach the vitreous cavity. Okay, so this was about certain procedures, certain instruments which I think are important for you to know, which I have revised. Okay, so that finishes our session of revision ophthalmology. I have tried to cover all the important topics to give you a comprehensive revision. I hope this will be useful for you. This will help you in your exams. So these are the points which you need to revise, which you need to stress upon. All high yield points which will be very productive for your upcoming exam. Okay, and as I told you, you can always post your doubts and queries to me, discuss with me through mail or telegram. I wish you all the best. Okay, keep yourself in very high spirits. This is the time when now we have to give our maximum effort there. Try to be consistent. Try to be don't let any kind of stress or anxiety overpower your preparation. Try to stay calm as much as possible. Let's be consistent. Let's do the targeted revision, and let's be prepared in the best manner for the upcoming exam. All the very best, my friends. I am thankful for your kind attention over here, and I hope you must have enjoyed the session. Thank you very much.